ever done, 840 people. So I get that may be small, especially compared to these contemporary studies, but this is the best we've got. So it's hard to ignore this study and adopt opposite conclusions based on smaller studies and say that this study is too small. This is the biggest one ever. 2, lack of diabetes. To me, I am really concerned about using low protein diets in patients that have diabetes, because these are not hypocaloric diets. So if you are lowering the protein intake, that means you are raising their intake of fats and carbohydrates. And I think that is a real dangerous thing without empiric data to do in patients with diabetes, right? This is something that should increase their A1C, something that is repeatedly have been associated with bad outcomes. So it is appropriate criticism. They did exclude this group. I think they excluded this group with good reason, and ignoring the data because of that does not make sense to me. Overrepresentation of autosomal dominant polycystic kidney disease. I think this is a legitimate concern, right? We do not think that ADPKD is a glomerular disease. Low protein diet is supposed to be an intervention to prevent glomerular sclerosis. Makes sense that this would be a poor population to study, but even if you exclude these patients, there was still no signal, and it is still among the largest trials. Relatively short follow-up period, absolutely. This is a big problem. I believe that there was a lot of arrogance that they were using iothalamate clearance, and they thought that they could do a sprint type study, a very short study, and because they had precise measurements of GFR, they would be able to draw important conclusions from this. I just think this is a poor study design. You do not see this being replicated anywhere else. Nobody's decided, nobody has looked at MDRD and say, that's the way we should do it. Everybody agrees that we need to do longer studies for that. That said, if we look at our contemporary studies with highly effective drugs, we are finding difference, and larger studies with highly effective drugs are getting positive outcomes in 2 years-ish. Failure to separate the temporary short-term versus more persistent long-term effects on GFR. This is a debate we are still having today about in CKD progression. We know that many of our interventions cause an acute drop in GFR, and should we ignore that acute drop in GFR and look at that? And this is the looking at surrogate endpoints, whether it's total slope in GFR versus chronic slope in GFR. Let me show you what this looks like. So this is a pattern that we see with ACE inhibitors and SGLT2 inhibitors. Thank God we don't see it with GLP-1 receptor agonists. Well, we get this acute drop in GFR, and then we have this flattening of the long time curve. And the classic way to look at this is to do what's called total slope. You say start at the beginning, and you look at the end, and you look at their total slope. A more sophisticated look says, hey, that acute drop only happens one time. And the longer that we follow these patients out, the less relevant that acute drop is. And if we want to get a better sense of what the long-term outcome is, we should just look at the chronic slope. This is I think, a incredibly compelling argument. And so this meta-analysis that was done said, well, let's take a look. Let's put all of our ACE inhibitor studies together. Let's put all of our SGLT2 inhibitor studies together, and let's see which of these two better predicts outcome. And surprisingly, at least to me, and this is how they presented the data. Boy, if you could figure this out, you are smarter than me. I throw it here just to pretend that I'm smart enough to understand what I'm looking at. I have no idea what this represents, but the conclusion was that total slope, as of today, is still a better predictor of these outcomes. Okay, and so it is intellectually compelling to say that chronic slope is going to be the one that is better predictive, but that is not what our data shows. Our data shows that total slope is the better predictor for long-term outcomes. It was a better predictor in MDRD, and it is a better predictor in our current studies. And so I think that this criticism that Cam Calentire had, I think, is misguided. And then last thing that he says is discounting secondary analysis. I just showed you the secondary analysis, the long-term follow-up. It is not compelling. This is find it frustrating that the editors of the New England Journal of Medicine did not call him out on this, because the secondary outcomes are not compelling and do not show good outcomes. And then discounting racial disparities, said that African-American patients had greater benefit from dietary protein reduction. I don't know, it's a non-pre-specified secondary analysis of a negative trial, and it was not further addressed in the review article. I don't know what he was getting at here. I don't know what to think about this. It seemed kind of like something that's, I don't know why he put it there. So I don't know what to think about it. So this is the 2012 CKD guidelines. So this is where we were before last March, or before the Peidoki guidelines came out. So it just suggested, based on the data that I've shown you already, 0.8 grams per kilogram per day in adults with diabetes, and giving it a very low evidence grade of 2C. And then without diabetes, 2B, a slightly better grade, but not great at all. And then reserving that for people with GFRs less than 30. And that they suggest avoiding high protein intake. Again, very shaky evidence of 2C. And that their comment was, in all studies, compliance with a low dietary protein intake was poor. There was no convincing or conclusive evidence that long-term protein restriction delayed the progression of CKD. So this is kind of, when I read this, I was like, yeah, that sounds about right. Okay, 2C, 2B, I mean, to me, those are very soft recommendations, the things that should not result in policies being made and pay for performance or any kind of other guidelines. And then this is just to kind of give you a sense of, when people talk about dietary protein restriction, what are we talking about? There's all kinds of different definitions here. And when we talk about low protein diet, that's usually 0.6 to 0.8. And below that's going to be a very low protein diet. And moderately low protein is going to be 0.8 to 1.0. And I just wanted to point out that if you look at like the FDA's recommended daily allowance of protein, it's 0.8. So when we tell people to go on a low protein diet, we're really just telling them to go on a normal protein diet. That's 0.8. That's what the recommended daily allowance of protein. Now, I get that Americans on the typical American diet eat a lot more than that, but what we should be telling patients is just, hey, just a normal protein diet is fine. Right. And you see patients and you're like, okay, for you, it's gonna be 60 grams a day. And people are like, oh, that's plenty. It doesn't feel restricted when you put them on the 0.8, and because that's a normal protein diet. So this is the article that drove me nuts. This is the 2020 Peidoki nutrition in CKD guidelines. And this was, first of all, Peidoki, after the introduction of KDIGO, had really fallen off of my radar. Like when I was a fellow, these were the only guidelines. They were the first nephrology guidelines. They were an absolute revolution. These were the ones that established eGFR. These are the ones that established CKD stages. Like they were amazing. But KDIGO kind of superseded them. And what Peidoki was left with was just kind of commenting on and adapting the KDIGO guidelines, which are international, to be more specific for the US. And they were sponsored by the National Kidney Foundation, and it was great. And these are not based on KDIGO. These are not a commentary on KDIGO guidelines. They just said, we're going to establish new nutrition guidelines. They paired with the Academy of Nutrition and Dietetics, and they said, in adults with CKD stages 3 to 5, who are stable, we recommend, under close clinical supervision, protein restriction with or without keto analogs. And they were looking at a 0.55 to 0.6. So they were going to a low protein diet, or they also equally suggested a 0.3 to 0.4, so an extremely low protein diet. And I want you to point out that they gave a 1A guideline to this. So they're recommending everybody with a GFR less than 60 go on a low or extremely low protein diet. And they gave it a 1A guideline. This is the kind of the history of protein restriction guidelines that we've had going from 2000 to these guidelines that came out in 2020. And you can see that these guidelines are the most severe protein restrictions that have ever been recommended. And they're the protein guidelines that go for the highest GFR ever. Nobody had ever had the arrogance to suggest to use low protein diets to a GFR all the way up to 60, less than 60. I mean, I don't know how many little old ladies that come into my clinic with a creatinine of 1.3 and gives them a GFR of 48. And I can't imagine that they gain anything from going on an extremely low protein diet. These patients are never going to have a kidney outcome, but there was no humility in these guidelines at all. Right, and I want to point out that the KDIGO guidelines recommended 0.8, as does the United Kingdom Kidney Association, which are normal protein intake, not low protein diets. So very, very severe. And I want to just, again, I want to focus on this 1A that, for me, 1A is a sacrosanct place. You need to be real careful when you do 1A guidelines. They say that by an A guideline says that we are very confident that the true effect lies close to that of the estimate of the effect, and that for policy makers, they say this recommendation can be adopted as policy in most situations, including for the use as performance indicators. Right, so this is KDOQI telling leaders of insurance companies that, if you want to set up a guideline that is appropriate to tell everybody who's got a GFR less than 60, we think that the evidence is strong enough for this. And I want to just kind of look at other guidelines that we use all the time. So recommendations to quit smoking, that's a 1D guideline. Recommendations for a low sodium intake in CKD, it's a 2C guideline. ACE inhibitors and angiotensin receptor blockers in diabetes is only 1B. And ACE inhibitors and angiotensin receptor blockers in proteinuria kidney disease is also 1B. ACE inhibitors and angiotensin receptor blockers in people with a non-proteinuric disease is 2C, and a blood pressure target of less than 120 is 2B. I suspect that's going to get upregulated given the data that we've seen come out this year. This is the section in the KDOQI guidelines where they defend their 1A guideline, and they said 3 studies clearly indicated a benefit effect of moderate restriction in dietary protein on the development of end-stage kidney disease and death. They referenced these 3 studies. So I already showed you the Locatelli data, which was the Italian study that had a p-value of 0.6. I don't know how that becomes a compelling study, but that's one. And so here's a review of here's your point value of 0.6 with the Locatelli data. I want to point out also that they, in Locatelli, they looked at the patients that were supposed to be on 0.6. They did dietary recall. They were getting 0.7, and then they measured their protein intake, and it was 0.84, actually a normal protein intake. So maybe one of the reasons there was no separation in Locatelli is there was no separation in protein intake. But boy, I have no idea what you're thinking to use this study as one of your 3 studies that supports your 1A guideline. This is a completely negative trial, insane. Rossman was another study that they supported. This is 1985. So here it is in the reference. It's from the proceedings of the European Dialysis and Transplant Association, European Renal Association. This is the progenitor of NDT, nephrology dialysis and transplantation, from 1985. There is no internet record of this journal at all. Going from the you can find it in PubMed, and you can find in their evidence review as part of KDOQI, you can find this reference, and you can kind of see, oh, it's 199 patients. So here's a summary. It's 199 patients randomized to either usual care or 0.4 to 0.6. Their endpoint was renal survival. Since I can't pull the article, I don't know what renal survival means. But they did find a significant difference with 30 to 35% renal survival in the usual care versus 40 to 55%, which is a weird way to present your data, in a range like that. I don't know what's going on. The thing that I could find is the previous reference is 167, and this says long-term follow-up of an initial study. I suspect this is the long-term follow-up of that initial study. That study is Kidney International. It is fully available. You see the same, they segmented their population just like MDRD, with patients with higher GFR getting higher protein intake and lower GFR getting lower protein intake. Very, very small study, right? This is the same group that criticized the small size of MDRD with its 800 patients, looking at a study with 70 in an arm or 40 and 50 in an arm. And here you can see in the high GFR group, and completely no difference. Their outcome here was creatinine clearance, but in the looking at dialysis, which was defined as a creatinine clearance less than 4, nice separation between those two groups, with again low protein diet seeming to be significantly better. But, and again, this is something that we'll see oftentimes. It's hard for me to swallow that there's a big benefit in dialysis if there's no benefit in progression of creatinine clearance. I just don't know where that comes from. And then again, in conclusion, after 4 years of follow-up, we are only moderately optimistic about dietary protein restriction as a general measure for the management of the progression of chronic renal insufficiency. So the authors of the study don't think that they have been able to demonstrate good progression, but the people writing the guidelines 40 years later leave this as one of the 3 studies that support it. The last one is Hansen from 2002. This is a study of people with type 1 diabetes, 40 in an arm being randomized to 0.6 or usual care. Again, great separation with their composite of dialysis and death showing significant benefit with a low protein diet. But when you look at their outcomes, there was mostly deaths in the low protein, in the high protein diet that was really driving the differences. And when they actually measured the protein intake, it was 0.9 versus 1.0. And I can't be more skeptical that this difference in protein intake is driving mortality differences in a 4-year trial. It just doesn't, I don't buy it. I just think this is, I don't know what they're measuring here, but I don't think they're measuring a difference in protein intake on dietary outcomes. So, and then, we're taught that, make sure you're skeptical of single center trials. Single center trials are the ones that are more susceptible to fraud. This is not a single center trial. This is literally everybody was taken care of by one doctor and one dietitian. This is a 2-person trial in terms of the intervention. Again, with these outcomes, it's just not believable to me. So these are the 3 studies. I find them all to be crap. Later on, they say, they point to a study that indicated cumulative incidences of death in dialysis therapy were unaffected by the diet regimen and a low protein intake group. 0.55 does not seem to confer a survival advantage. So they're trying to address a negative trial here. This is a trial with 423 people. They criticize its being of small size. Again, here's their outcomes. There's no difference between the 2 diets. And then here's the breakdown of the different outcomes: death, dialysis, or the composite of that. Those Kaplan-Meier curves are completely on top of each other. And the low protein diet did not decrease the risk of death or dialysis therapy initiation compared with the moderate protein diet. And they said that this was by the relatively small sample size, even though it's way larger than their trials that they point to as being positive. This, in fact, is the 3rd largest randomized controlled trial of protein restriction, only behind Locatelli and MDRD, also negative trials. And then this line: pooled together results from the secondary analysis of the number of events of death in ESKD combined from the 3 studies indicated a beneficial effect of protein restriction on death or ESKD. They don't specify which 3 studies. I believe it's the 3 studies that they pointed to that were positive. And this is not how we do systematic reviews. You don't take the 3 positive trials and then put them together and say, look at what we found when we did these 3 positive trials. You're supposed to take all of them. This is not like, nobody does this. It's incredibly frustrating to me that Kedoki allowed these clowns to publish this. And I think what happened is that the only people that are interested in dietary protein restriction are the people that believe in dietary protein restriction, and they got in the room together and they looked around, they're like, oh my God, we're the only people that are making the decisions here. We can write whatever we want. And there doesn't seem like there was good peer, and I don't know what the peer review looked like. I don't know if they, oftentimes you get to pick who your peer reviewers are, and if they were very selective in who they send them to, but this is not my area study. I am doing a very, this is something that just it intrigued me initially, right? I was like, wow, that's interesting. I must have missed something. Found out that I didn't miss something, and then I was outraged, right? I don't have expertise in here. I just did basic internal medicine, evidence-based medicine rules, and looked at the stuff and was like, just got angry. Here, if you read on the guidelines, so we just said that they just said that the low protein intake reduces end-stage renal disease and death, an important outcome. Later on, they said, well, what does this affect on GFR? And they say in the same guideline, they say in adults with CKD, 5 randomized RCTs reported on the effect of protein-restricted diet on glomerular filtration rate. Results from all the studies indicated a low protein diet had no significant effect on GFR. Like in the same document, they're able to say, hey, it's great for preventing dialysis. It doesn't do anything to GFR. And you don't find that to be contradictory, right? This is not something that caused you pause. So KDIGO, which came out after this. Came up just last March. I'm sorry, the slide has the draft recommendations. The real recommendations are the same. They didn't change their guidelines. They were not affected. It's exactly what we said in 2012. They give it a 2C guideline for a low protein diet and not 1A. And so 2C. So very, very weak recommendation. And to me, I mean, we have a huge population. We have 10% of the world has CKD stage 3, right? Or worse. And I believe that protein restrictions is biologically active. Like I believe the Brenner hypothesis. I think that this is something that happens. We've seen repeatedly that this thing does have effects on the glomerulus. You are changing some glomerulus thing, but the current evidence base is old and insufficient to support a 1A recommendation. And if we are going to recommend this, right, diet is so culturally important. When you gave people dietary recommendations, you are separating them from everybody else, right? I mean, you know, we see this. Let me walk away from what I was going to say there. Let me just say that you need to be, I think we need to be incredibly careful when we give dietary guidelines, that these things really have profound effects. And I think they cause a lot of patient guilt, right? Patients have progressive kidney disease and telling them to restrict their diet. And then when they end up on dialysis, they say, I guess I just didn't listen to my doctor well enough, because if I had just gone on that low protein diet, done what he said, I would probably not be in this position. And I don't think that's the case at all. And I think we need to be really careful when we blame patients for these outcomes, because I just don't think that's there. And none of these studies were done with contemporary. Many of them specifically excluded ACE inhibitors. Locatelli study excluded ACE inhibitors if you were on them, or discouraged them. And certainly no GLP-1 receptor agonists and no SGLT2 inhibitors. And there's actually been a couple of studies that have looked to see, well, is there an interaction with protein intake and SGLT2 inhibitors? 3 studies have looked at this: Delight, Improve, and Diamond. None of the studies that I'm actually really familiar with. They're not kidney outcome studies, but they did get 24-hour urines. And so they allowed us to use that 24-hour urine. We can actually look at what their dietary protein intake is. So these are not dietary protein intake interventions, but we can categorize the benefit that they got from the SGLT2 inhibitors based on levels of protein intake. They divided the cohort into high and low protein intake, and we found no difference, no interaction with the effectiveness of an SGLT2 inhibitor with the amount of dietary protein intake. So, you know, you might think that they would be additive, but we don't have the evidence today to show that there is any additive. There's your p-value in action. And then here it is for dialysis, same thing, no interaction. So, no, does not appear so. So that's what I have today. I'm happy to take questions. What do you got?
Did the authors push back on any, I mean, did you bring up any,
I did not, I was not aware of this during the comment period. I didn't notice this until it got published. And we wrote an article in Kidney Medicine, and it was peer reviewed. And there was almost no pushback in the peer review. We published almost with unchanged, if I remember correctly. And there was no letters to the editor or anything like that. And I have not bumped into any of the authors since then. So I wonder what that will be like when it happens.
I remember in one of the next steps, in fact, it was one of the trick questions that do you recommend protein restriction for patients or not? And the answer was no, because the protein restricted people, they don't do that on down.
They don't. Yeah.
It's amazing that this was before COVID, 2018.
Yeah.
that they came up with these type of recommendations?
It's-
Because such high grade,
It's embarrassing for the NKF. I feel, yeah.
I'm sort of intrigued, just slightly on topic, that the first couple slides you showed showing the pathway where albuminuria was sort of off to the left, but the mesangial cell. And it's interesting when you sort of think of the culprit cells over time. For a while, it was the mesangial cell was the bad cell, and then came the podocytes.
Yeah.
It is an interesting shift in a paradigm shift in how we perceive where the problem is actually happening.
Yeah. I mean, I think that
History of the glomerulus.
history of the glomerulus and the development, and I think the unlocking a lot of the genetic diseases and finding them being real important.
I also wonder if they're going to, because based on these recommendations, they shouldn't really be asking the starting albumin and when somebody started on dialysis, it's one of the parameters that they ask us to resolve.
Yeah, that's right. So there should be data on that. That's right. There should be good data on that. Good point.
Dietitians do seem also to be, I feel like the majority of dietitians are very into low protein diets.
Oh my
I still
God.
haven't figured out
Yes.
where that came from. In fact, when I initially learned this all from dietitians, I was like, okay, definitely low protein diet. And I only recently found out about the K-Doki guidelines. I
Yep.
didn't even know there was that.
Yeah.
But I
So
don't actually know where they initially got that from. And they've been telling our patients, like, I forget this here specifically, but I feel like throughout the country, they often tell patients.
you are 100% right. So one of my co-authors, Swapnil Hiremath, was in a debate at the last World Congress in Nephrology in Argentina, and he took the position that what I just outlined, that we should not use a low protein diet, and he got mobbed afterwards by dietitians, and there, no, he did, right, and it was all like, we know that this is true, right, and the K-Doki guidelines were co-sponsored by the American Dietetic Association. Like, you're definitely seeing, to me, it's concerning that there wasn't a well-established pushback and peer group. I don't know why. And again, I guess I'm guilty because there's a comment period before all these get published. And I guess we didn't comment strong enough, and I wasn't aware of it. And now so I was at the NKF last year, and I was at a lecture, and when this came up, the dietitian presenting kind of presented the old the KDIGO data and said, well, the KDIGO data is old. And if you look at the most recent comprehensive review, it gives it a 1A guideline. Full stop, right? Like, that's the thing that, you can remove arguments by saying, I've got a 1A guideline on a national guideline. It's incredibly powerful at generating consensus of people that are not familiar with the data. It was a dirty move.
One of the nutritionists actually just messaged me and said, do you recommend a renal diet for this patient? And a renal diet is automatically the protein restrictions. Now I'm gonna have to say no.
Yeah, I tease the residents. I call, there's the number needed to treat the NNT. I have the NNC, the number needed to complain. Like, how many people do you have to prescribe a renal diet before you get a single complaint about how bad the diet is? So, yeah, our hospital, we have 2 renal diets. We have the dialysis population that get a 1.3 grams per kilogram, and then we get the pre-dialysis patients that get a 0.8 or 0.6. So yeah, no, that's exactly right. That this has been established by dietitians as this is the way you treat CKD, and it's frustrating. And so you do have to push against that and understand that you're pushing against their entire kind of paradigm that they've been taught about kidney disease. Yeah.
Maybe based on age, like majority of our CKD population is increasingly an older population, and yet they do have sarcopenia, and they have frailty, and so I think.
100%. And I think that's an important thing to remember, is that CKD, being a gerontology disease, only comes up after you have estimated GFR, where age becomes this huge factor in generating those low GFRs. And the bulk of this data doesn't come from that time. It comes from before that. And I think most of this data probably happens in young people, right? Because they were looking at people with absolute increases in creatinine rather than people with decreases in GFR. And I think that's a great point. I should add that to my slide set, because I think yeah, absolutely. Maybe this is and maybe part of the thing that reaching is harmful.
In the extreme protein, or the very extreme
Yeah.
protein restriction, where were the calories coming from? Was there overall calorie restriction? was it more fat late at the time in the eighties?
Yeah, so right, there's only three macronutrients, so it's either carbs or fat, right? And these extremely low protein diets. And so one thing they did follow is they do look at malnutrition. So they have nutritionists that are following them, and this is a big finding of the MDRD is that these were, they quote, well tolerated. They didn't have abject malnutrition. They did find, again, no diabetics, where I would be certainly concerned about an increased carbohydrate diet in that population. But they, according to the article, no malnutrition.
You can see a distinction in terms of the etiology or multiple myeloma versus.
I mean, I don't feel the need to ever put on patients on a low protein diet. I never do that. And so I would be, I guess, there's people say, oh, in proteinuric diseases, you need to be worried about that because they're going to be losing 2 or 3 grams of additional protein in the urine that we don't normally account for. And so you need to deal with that. I just don't ever use it. So I don't know.
The only thing I recommend is to avoid excessive intake of food. But if there's a nephew who's working out in the gym, don't start sharing food with him because he may be eating 15 eggs a day. That's not good for a CKD. That's not right.
Yeah, right. I think so. Okay, I think we all do this, right? None of us want to see our patients on two because you do have patients that come in and ask you about 2 grams per day, and my eyes pop when I hear that because it's so I'm so focused on this way lower scale, and I've definitely I think we've all seen isolated episodes of FSGS from patients on a high protein diet, and whether that is causative or associative, I don't know. And I have not seen good empiric data that high protein diets are etiologically bad. That said, you're very consistent with the current kidney eco guidelines recommending nobody being on higher than 1.3 grams per day if they have CKD. And so I think we all do it. I'm just not aware of empiric data saying that it's truly bad. And that said, it is really hard to study things that we know are bad. We can't randomize people to things that we think are bad. We need to get our data some other way. So that data may be up where I'm not aware of that. But yes, that's what I do also. What do you do when they say, can I have creatine?
I can tell you one of his patients, Dr. Stan's patient on the outside, he said, oh, I would love to have a slice of pizza. I said, go ahead and do it. I'll buy it for you. And it's not going to hurt you. You already got that. You came up with it. So.
And he came off the house and sure the power of pizza. I am in favor of that. Yeah, no doubt. There's another lecture just like this on CKD MBD, which has been a morass of bad data also. Okay, hey. Tell me, you guys are transplanting myeloma patients? How do you guys do that? Wait, bone marrow transplant or kidney transplant? And then his kidneys got better?
Well, but
And he got off of dialysis with a GFR of 12.
I mean, he really didn't want. I mean, he was fine. He was interested. He was fine.
People get off of GFR 12 is fine. I mean, not fine, but good enough, right? Yeah. Okay. A lot of conflicts of interest. So this is kind of what got me interested in this topic. Is in 2019 there was this review article in the New England Journal of Medicine, and they were now calling it contrast associated acute kidney injury, and I was like, that's not what I was taught that it was called. It was contrast induced nephropathy, and then I was like, well, maybe I'm just wrong, and I went back and said, oh yeah, the last time they reviewed it in 2006, it was contrast induced nephropathy, and I was like, well, that's an interesting kind of walk back. And then in 2020, the National Kidney Foundation published their guidelines on contrast, and they said the risk of acute kidney injury developing in patients with reduced kidney function following exposure to intravenous iodinated contrast media has been overstated. And I love the passive voice here, as if the National Kidney Foundation hadn't been leading the charge against contrast use for many years before finally backing off in 2020. And I really am presenting the conclusions at the beginning of the lecture, mainly because I know that lots of people will not stay to the end. That's just kind of the nature of lectures. But in that same statement, the American College of Radiology also agreed and also added that prophylaxis is not indicated for the general population of patients with stable GFRs greater than 30 or for patients at risk for heart failure. And I start to think about, how many patients that we're giving contrast to that I get called on to, can we give contrast to these patients? I'm like, hey, what I'm going to present is kind of the evidence that led to these conclusions, but that these are the conclusions. And this is not, when I first started giving this talk, I was kind of like, I felt like I was a cowboy out there in the wilderness. And now this is really the positions of the National Kidney Foundation and the American College of Radiology. Right. So here are, this is kind of where medicine is, and just this the pendulum is all on safety. And this is where I am. I am like a cowboy, give it to everybody. And where I kind of hope that at the end of the lecture, you guys are somewhere in the middle. I want to start with a case. This is many of these cases, in Grand Rounds, they're completely synthesized out of a patient's imagination or a doctor's imagination. This really happened. This was on a Saturday. We had a dialysis-dependent acute kidney injury. Patient was intubated. This was a Saturday morning. And overnight, the patient had worsening acidosis. It was a combined metabolic and respiratory acidosis. And surgery wanted a contrasted CT of the belly. They were worried about a perforation. And so the nurse called me and said, can we give this patient contrast, right? The nephrologist with the calculator. I said, that's no problem. They sent that message then to the surgery resident. Nephrology is cool with that. Radiologist said, no, we can't give contrast. This patient's got an elevated creatinine. Surgery resident then called me. I called them back, and this is all happening on a Saturday. Everybody's busy. Everybody's taking care of too many patients. And we finally do get the CT scan done. The ball goes right through the center of the CT scan. And sure enough, there was a perforation. We did find that, probably didn't need the contrast in the end. And the patient goes to the OR. But what started a process that was started on Saturday morning results in the patient not going to the OR till 3 a.m. on Sunday. And the patient ended up dying. And I don't know. This may have been unavoidable. This death may have been unavoidable, but I know that patients going to the OR at 3 a.m. is not as good as patients going to the OR in 2 in the afternoon, right? And this patient doesn't develop contrast nephropathy, so no review of contrast nephropathy is going to be able to see all the stuff that happened to this patient just for the fear of contrast nephropathy in a patient who was already on dialysis, right? Like it was so unnecessary. But again, there's this culture of safety medicine, which is great. We love this culture of safety, but we just need to understand that there are consequences anytime we try to put up rules and barriers to try to assure safety. There's something on the other side of that ledger that oftentimes gets ignored. So we have this walk back from 2006 to 2019, but there is some consensus. And this is one of the things that we know, or we've established the definition of contrast-associated nephropathy as a creatinine rise of at least 0.5 milligrams per deciliter or 25% within 2 to 5 days of contrast administration. In pediatrics, we changed the rule a little bit, increases 0.5 milligrams per deciliter. And we all see people that fit the definition of contrast nephropathy all the time, right? And so I think this is one of the things that makes it difficult for us to see this is like, I've been taking care of patients with contrast-associated nephropathy my entire medical career. And I think this definition is the original sin in this whole field, okay? I think this definition is terrible. And I want to compare it to the definition of hepatorenal syndrome, right? So this is a diagnostic criteria of HRS. This is not actually the most recent one. It was recently changed, but one, they require a diagnosis of cirrhosis and ascites. We are going to set the setting in which these patients can get it. And this is something that we also have in contrast nephropathy. These are patients that received contrast within 2 to 5 days. This is cool. Diagnosis of AKI according to ACA-AKI criteria. This is also incorporated in the definition of contrast nephropathy, this increase in creatinine to 25% within 2 to 5 days. But then look at the rest of the definition. No response after 2 consecutive days of diuretic withdrawal and plasma volume expansion with albumin. What are they trying to do? They're saying, make sure you don't confuse Pre-renal azotemia with hepatorenal syndrome. So try to do a volume resuscitation. This is nowhere to be found in contrast nephropathy. Absence of shock. Make sure you're not going to include people with ATN in the definition of hepatorenal syndrome. Well, we don't do that in contrast nephropathy. No current or recent use of nephrotoxic drugs, NSAIDs, inflammatory drugs, aminoglycosides, all other alternative etiologies of AKI are specifically excluded from the definition of HRS, and none of this exists in this definition of contrast nephropathy. So with liver disease, we get the patients with liver disease, and we get all these people with the AKI, and they say, but we're only going to take these few patients that don't have alternative explanations. Well, with contrast nephropathy, they're like, we're taking them all. We own them all, right? All of them are contrast. It doesn't matter if they've been, on aminoglycoside and hypotensive and in shock, we're going to take them all. And you can create, now this one's a totally synthetic case, absurd situations. A patient a year ago gets diagnosed with lung cancer. They go for pneumonectomy. A year later, their creatinine's 1.2 and they're going for a surveillance CT scan to make sure that they don't have recurrence of their lung cancer. And thank God the CT scan is negative, and they go out and they celebrate afterwards because they are still cancer-free a year ago. And the next morning they wake up in a bathtub full of ice with a message saying that both of their kidneys have been stolen and they better seek medical attention. They go into the hospital and sure enough, they have no kidneys and their creatinine is already up to 2.4. And the doctor says, wait a minute, you had contrast yesterday? Your creatinine is now 2.4. This is contrast nephropathy, and it does fit the definition of contrast nephropathy, and you have an excellent prognosis, right? And it's an example of absurd. Now, one of the things that happens when you define contrast-associated nephropathy as a bump in creatinine, regardless of cause, it becomes easy to do retrospective studies of incidence, and whatever. There's a million of them, right? And we will just, and if you take a look at those, their incidence ranges from 1 to 11% in patients with chronic kidney disease. And the question that should come up to you is like, well, if we get 1 to 11% of patients getting a bump in their creatinine at 25% after receiving contrast, well, how often do hospitalized patients have a bump of 25% without receiving contrast? And I ask this question only because it has been done, right? And so this is a retrospective study from a large academic center. They took 32,000 patients that had received no contrast for 10 days prior. And then for the next 4 days, they measured, or 5 days, they measured their creatinine on a daily basis. And they just wanted to see among hospitalized patients, how often do they cross the line that they would be defined as a contrast-associated nephropathy. And sure enough, by day 2, they had about 18% of patients having contrast-associated nephropathy. And this is like a control group where when you look at these retrospective studies, there are no controls. So that's 17%. And so, this is kind of a representation. In stable patients, nobody crosses that line into acute kidney injury, but hospitalized patients are completely different. They're NPO this day, they're getting aminoglycosides this day, they're maybe getting over diuresis the next day. And a lot of them will cross this line into acute kidney injury, but but kind of intentionally we set this AKI line as being highly sensitive so we can get on top of these patients, get a nephrology consult and catch this, nip this in the bud. So we know that there's lots of false positives with this. So if you look at retrospective reviews, incidence of CIN ranges from 1.3 to 11.1 among CKD patients. How often does the creatinine rise 25% without contrast? Looks like, at least in this one study, was 17% that would meet the definition of contrast-associated nephropathy without the contrast. And so right now, when people get contrast and they get AKI, we consider all of them to have contrast-induced nephropathy. And maybe that's not the case. And like this is another case that happened to me. This was a patient who came in with a creatinine of 1.9, and after that creatinine 1.9, they got contrast, and they were declared in the consult note as contrast-induced nephropathy. Contrast being so toxic it actually goes back in time and causes the AKI before they get exposed. So maybe the reality is that only half of these patients actually have contrast-induced nephropathy and the other half of incidental AKI. Or maybe contrast-induced nephropathy is incredibly rare and all of it is incidental AKI. Most of these studies, you get contrast and you look at the rates of AKI. And what we actually need is something that I like to call a control group, where patients get contrast or don't get contrast, and you look at the rate of AKI. And that would be helpful for looking at this. And this, this is called a controlled trial. And the best type of controlled trial is a randomized controlled trial. And I will not be able to show you a randomized controlled trial. There has been one that is attempted. We'll talk about that a little bit later, but most of this has never been done. But that's not the only type of controlled trial. And so one of the early ones was done at Hopkins, urban ER, 75,000 visits. And they looked at abdominal and chest CT scans with contrast and without contrast. And I want you to first take a look at the numbers, the absolute numbers of patients that get chest CT scans. It's 7,000 with contrast and 900 without contrast. And that's because the study is better with contrast. You get more information when you get contrast. Everybody wants to get the contrasted CT scan if you can. Then they balanced the groups by age, gender, and diabetes status. And then they looked at the rates of AKI with contrast and without contrast. And they found a higher rate of AKI without contrast than with contrast. Now, the p-value is not significant. I'm just looking at the absolute point values. And I don't want anybody to be suckered into this and say that this is a compelling trial, right? Because we know that even though you've tried to balance the groups, who are the patients that are not getting contrast? Those are the patients that are going to have worse kidney function, right? The people with 2 nephrons left connected by scar tissue are the people that you're not going to give the contrast to, and they're going to be the people that are naturally at higher risk of contrast nephropathy. And so what followed then, and I didn't just cherry pick this one. If you take a look at systematic review and meta-analysis, 13 observational and controlled trials of 26,000 patients. And this was the finding, is that they did found here the p-value approaches significance, but no difference with the rates of contrast nephropathy. The problem with being a blogger is that you have to live with what you thought in the past. And so this was from 2013 when this comprehensive meta-analysis came out. I pointed out the problems that the confounding of the data on people that do not get contrast, and, contrast is still toxic. And so what came up with, there was propensity match trials. And I just want to take a moment to kind of describe what we're doing. So everybody has an inherent risk of developing AKI, right? And you could graph that out, and you can put people all the way to the left that have the highest risk and people all the way to the right that have the lowest risk. And you can imagine baseline creatinine, comorbidities, proteinuria. You can pick how you're going to do your propensity matching. And in a randomized trial, the 2 groups will have balanced risk. That's the whole point of the randomization, is you'll get equal number of people at low, medium, and high risk in both groups that would get contrast. But in the trials that we've been describing up to now, we get a shift where the patients at the highest risk are not getting contrast because doctors are smart and we don't want to put our patients at risk. And the patients at the lowest risk are going to be getting the contrast. And so you get this natural disequilibrium. And propensity matching just says, well, let's take this and match that up. Let's carve out or adjust our 2 populations. And so we get this balanced risk on both sides. And when they did this was the first one. This was done by McDonald and McDonald. They used 13 variables to create their propensity score. And this is how the propensity score goes at. And the colors are your GFR groups. And so I want to point out, look, even in the people with GFRs less than 30 or stage 4 and stage 5 CKD, you had a wide range still in your propensity score, from here all the way down to there, big wide range. And you can also see in terms of the non-contrasted CT scans, that's below the line, way more likely among those patients at the high risk, and contrast way more likely in the patients at the low risk. And so then after they did that, they balanced the groups. You get a mess of negative p-values across the GFR category, showing no increased risk of contrast-associated nephropathy or AKI following the contrast. And I remember reading this article and I was like, oh, McDonald and McDonald's a husband and wife team at the Mayo Clinic. He's a radiologist. She's a PhD researcher. And I was so relieved to see that they were sponsored by GE, manufacturer of contrast, so that I could ignore this data because it was highly conflicted based on their funding source. But that's been gruel, and it didn't take long for somebody else who did not have those conflicts to take up the same study mechanics and do this trial. And again, this comes out of, I believe this is, this is Hopkins. And they had 14,000 patients. Excuse me, and excuse me, and then they, with nothing disclosed, again, they found no odds ratio that was significant for AKI, no signal at all that contrast was causing AKI here. This is another trial that I loved because how many times have you written in your note or been seen written by nephrology? Patient now has AKI, nephrology is involved, and one of the recommendations is do not give additional contrast. Don't slap the kidneys when they're already down. Somebody said that's an interesting guideline. I wonder if, or recommendation, I wonder if we can put that to the test. So these are patients that had acute kidney injury, and KDIGO gives us guidelines on how to stage it, and it's just delta change in creatinine. Stage 1 is very mild, 50% increase in creatinine. Stage 2 is doubling the serum creatinine. Stage 3 is more than a tripling the serum creatinine. And these patients had AKI on arrival to the hospital. Most of them do not get contrast. A small number of brave doctors gave them contrast despite that. And then they looked at whether these patients developed persistent AKI depending on whether they got contrast or not. They looked at this with logistic regression and propensity weighting, and then something called entropy balancing, which sounds cool. I have no idea what it is, but what they found was, again, no signal at all that giving these patients contrast resulted in more persistent AKI at time of discharge. And so even though we all write it in our notes and it seems to make sense that you shouldn't give contrast to somebody who, especially somebody who's already in AKI, here we also don't have data to support that. They also looked at whether initiation of dialysis, and they actually found a lower risk of dialysis in with propensity weighting and with entropy balancing among patients that got the contrast, strangely enough, not what you would expect. And then this was the study that pushed me over the cliff. This was in most of the studies up to now have been published in the radiology literature, have been published in the ER literature, but nephrology had not published any of these trials showing the safety of contrast. And this study was published that looked at a massive sample of 6 million patients, and the risk of AKI without contrast was 5.6% versus risk of AKI with contrast of 5.1%. This was actually significantly, that contrast here was protective against AKI. I know it's hard to believe, but the reason this one pushed me over the cliff is one, this was published by senior also with Glenn Chertow, and he might be the most preeminent clinical nephrology researcher in the country. He used to be, he's a professor emeritus now at Stanford. You know, either a author on all the large trials in AKI and chronic kidney disease, or a reviewer or a member of the review board. Like he's a very prominent researcher, and for him to find this was very important. And then the other one is that it was in the Journal of the American Society of Nephrology, our National Association journal. And so I had my mea culpa when after I read this, coming here with my blog, confirmation bias, cognitive dissonance, and contrast nephropathy, just walking through that. And so this is what Chertow wrote in his article, is that the incremental risk of AKI that can be attributed to radiocontrast is modest at worst and almost certainly overestimated by patients, physicians, surgeons, radiologists, and other decision makers. Now, one of the concerns is that, you know, all this data is retrospective, and, you know, certainly when you see data that contrast is protective against AKI, it kind of makes you think that there must be residual confounding, that we're not doing a great job of controlling for that. And, you know, this can be very subtle, right? To serve as a control group, the patients needed to get creatinine after the CT scan, right? That's one of the important things. And, that means you're doing serial creatinines on this, and you don't do serial creatinines on everybody. You're doing this usually for a reason. And so these patients may subtly be at higher risk than we think about. And this may be one of the sources of residual confounding. And so this is a completely different way to approach this. This is called regression discontinuity analysis. And so this is looking at D-dimers, and the D-dimer at 500 goes from normal to elevated. And this changes behavior. So if you look at the chance that the patient is going to get a CT pulmonary angiogram, soon as it becomes abnormal, everybody gets CT angiogram, or at least the rate goes way up, right? And the idea is that people on either side of that D-dimer, right on the edge, are probably pretty similar to each other. People with the 499 probably look very similar to 501, but they're going to be treated very, very differently, because the people with 501 have an H next to that D-dimer, and the doctor is going to want to intervene on that. And the people with 499, it's normal black text. And so let's take advantage of this discontinuity. And the idea here is, so here you can see that these groups are very similar. There's no discontinuity with age. There's no discontinuity across that line with GFR. And there's no discontinuity across that line with diabetes. So this is exactly what you want to see. The only difference is going to be the discontinuity with whether they get contrast. And then the outcome they looked was long-term eGFR. Now, if the long-term eGFR looks like this would be presumptive evidence that contrast is bad for you, right? Because people on one side of the line, all of a sudden, even though they don't have a difference in age or GFR or diabetes status, they look a lot worse with long-term GFR. And if there's no effect of contrast, it's going to look like this. So what did the actual results were? It looked like this. There was no difference. There was no discontinuity analysis. Now, the authors, I would say, did not show much humility in their conclusions. They said, to our knowledge, this study provides the strongest evidence to date that intravenous contrast is not associated with significant kidney injury, further challenging the considerable clinical preoccupation with the occurrence and prevention of CIN. This study it is a population at extremely low risk for contrast-induced nephropathy. Average GFR was 86. They only had 12% diabetes, and it was 100% venous contrast. So there's reasons to believe that these patients would not be at high risk, and they, would have been nice for them to have a little bit more humility in their contrast. So this is a conclusions or discussion section from another study, one I'd already shared with you, one of the propensity matched trials. Indeed, our findings, along with those of several other retrospective studies performed in other contexts, support the notion that randomization of patients to receive intravenous contrast, once considered ethically infeasible, is very likely safe and will be necessary to fully understand the role of contrast media in precipitation of renal dysfunction. And GE was rubbing their hands for this opportunity. And so they launched this trial, contrasted CT scan versus non-contrasted CT scan plus ultrasound. They were looking for an indication where you could randomize patients to contrast. And the indication were people that had a stent placed for a AAA. With abdominal aortic aneurysm, after they get the stent, they need yearly monitoring for patients. And some vascular surgeons do CT scans. I know the vascular surgeon I use loves to get a contrasted CT scan. But other surgeons are fine with a non-contrasted CT scan plus an ultrasound, and they use that to monitor the AAA. And this was the opportunity to do a randomized trial, to randomize to those two strategies. And you can look this up on clinicaltrials.gov, NCT 03119662. And you will find when you do that, that this study was terminated due to lower than anticipated recruitment rate. The decision has been made not to do any safety reasons. So there was no safety signal, but they couldn't get recruitment. And what this really says is that, we had poisoned the well. We had told doctors for so long that contrast was bad, that when doctors were told, we're going to randomize your patient with chronic kidney disease to either contrast or no contrast, they're like, no, you're not. I'm not letting my patient get enrolled. And they couldn't recruit patients. And so, unfortunately, we will probably never get the opportunity to do this trial because even, it's this weird discontinuity that people that study contrast, that are experts in this, have equipoise. But the general physician out there, they don't have equipoise. They've been taught by people that they respect that contrast is bad. They read it, they see it They see contrast-associated nephropathy all the time because of a bad definition. They read it in every consult note that nephrology says, don't give contrast because they have AKI, don't give contrast because they have CKD. You know, the NKF, which says we probably overestimated the problem of it. Yeah, probably. So far, all the data I've presented has been on venous contrast. And that is not probably the biggest source of contrast now. We have arterial contrast, which is, well, I'm not sure if it's the biggest, but big concern. And what we know is patients who get arterial contrast have a higher risk for acute kidney injury following that. And it's impossible to do the controlled trials that I've already demonstrated. I know the trials haven't been randomized, but they have been controlled. We don't have the same opportunity with arterial contrast. But we do have some advantages. We can look at dose of contrast and see if there's a dose effect. And we can look at alternative definitions of contrast-associated AKI. Let's take a look at dose of contrast. So this woman is at Sinai, I believe, Dr. Marin. She's a cardiologist, and she studies contrast-associated AKI following cardiac caths. And her preeminent publication is this Marin score, which allows you to predict post-cath rates of AKI. And you can look at the score here. There's a lot of criticism of the score, but the thing I wanted to focus on was, oh, and here, and she's updated the score in 2021. But the thing that I wanted to focus on, oh, here's the data here, the derivation group looking at their risk and their predicted acute kidney injury. And the validation group, it worked very well. But I want to focus on the score that you get for contrast volume. That less than 100 cc's gives you 0 points. 100 to 199 cc's of contrast gives you only 1 point. And these other volumes of contrast are really quite high. And I just talking to the cath cowboys at my hospital to say, well, how much volume are you guys using? And their volumes are ridiculously low, right? I mean, there's just the developments, the advances in cath technologies allowed us to do use smaller and smaller doses. And you can just see we're using very, very low doses. And so the contribution of the contrast volume to this score is tiny. And the other thing is, though Marin does find that using more contrast results in higher rates of contrast nephropathy, more contrast is probably indicative of a more complex case, a sicker patient, someone who have a higher background rate of AKI, so maybe not do the contrast at all. And so you would need, what if you could randomize the dose of contrast? And it sounds absurd, but it's actually been done. So this is a device called the AVERT device, and this allows you to use less contrast. And from what I understand, all this device does is spill some of the contrast on the floor. So when you inject it, not all of it goes into the patient. Okay. It sounds absurd, but this is a FDA legalized product. So 578 patients, average GFR of 45, 65% of diabetes. They actually got a pretty sick cohort. And in their phase 3 trial, they found a 16% reduction in contrast volume. And if they were doing a PCI, they actually had a 23% reduction in contrast volume. And that reduction in contrast volume did not result in any improvement in the rates of AKI. So pretty significant reduction in contrast, no improvement in outcomes. And then this is a endovascular ultrasound. So this is a huge advancement in PCI technology. It allows us to get better three-dimensional views of the vessels that we're looking at. And then this was studied in a randomized fashion. They also found a significant reduction in contrast volume. Look at the going from 64 cc's to 20 cc's. So now a 2/3 reduction in contrast. And that this did not result in a change in their peak creatinine or their lowest GFR or their rate of contrast nephropathy, p-values in the middle, all non-significant. So dose of contrast doesn't seem to affect this. It starts to make it difficult to believe that the contrast may be toxic at all. And then alternative definitions of contrast-associated AKI. So we looked at this in the hospitalized patients, the problem with this rate of AKI. And so maybe instead of maximizing our sensitivity, maybe we could try to maximize our specificity. Because this is the patient we're looking for. The patient who develops AKI and keeps on going, gets sick, and ends up on dialysis. And so what if we used death, dialysis, or permanent decreases in creatinine to look for that and to make sure we're looking for true positives? And we have probably the best study ever done on contrast-associated nephropathy. It is the PRESERVE trial. It was a trial that was looking at whether sodium bicarbonate or N-acetylcysteine reduced the risk of contrast-associated nephropathy. And they used this definition, this death, dialysis, or 50% increase in creatinine at 90 days as their endpoint. And they had 5,000 patients enrolled in this trial. And you can kind of see the distribution of outcomes where they got this. They had 226 outcomes, and about a quarter of them were this permanent decrease in GFR. Another quarter of them were dialysis, and half of them were death. Patients that were enrolled had severe kidney disease. Average GFR was 50, but 40% of them had a GFR less than 30. Average age was 69. Contrast volume was 85 cc, so pretty good contrast volume, and 85% of the patients were diabetics. They did measure the traditional contrast-associated AKI, so you can correlate their important outcome with the traditional outcome, which is what we will do here. So they had about 10% of their patients get contrast-associated AKI. But if you looked at the patients that ultimately developed their composite outcome, most of those patients did not receive their composite outcome. In fact, more people that didn't have contrast-associated AKI by traditional definition ended up with that composite outcome, which is weird if you think the composite outcome is important. And then you can kind of do your sensitivity and specificity and likelihood ratio and find that that contrast-associated nephropathy, as traditionally defined, was a very insensitive marker of what I would consider an important patient-oriented outcome. As part of this trial, they also looked at biomarkers, right? So, when we look at creatinine, that is a functional marker. And we are, if we used functional markers in cardiology, we would be diagnosing heart attacks by blood pressure and EKG changes. And we do some of that, but mainly we look at biomarkers, troponin and CKMB, et cetera. And we have biomarkers in nephrology, we just don't use them, and they're mainly used for research. But in the PRESERVE trial, in a sub-study, they looked at biomarkers in patients. And so this is a sub-study, 922 patients in the PRESERVE trial. Of those, 849 did not develop contrast-associated nephropathy, and 73 of them did. And this is what happened to the biomarkers. So the light blue is the patients that did not get contrast-associated nephropathy, and the dark blue are the people that did get contrast nephropathy. That barely shows up. And you can see that all those markers, or maybe you can't see, are the same. And their conclusion was the absolute change in relative ratios of plasma and neurobiomarkers were modest and comparable between patients with and without contrast-associated AKI. But what you're really thinking is, Topf doesn't know how to make a graph. Why do you have the y-axis so small? Because I wanted to kind of show what happened in other conditions. So green are people that run a marathon. And some of the people that run a marathon actually meet the definition of AKI. And you can take a look at what their biomarkers do in AKI and compare that to the people that developed contrast-associated nephropathy. Marathons, horrible for your kidneys, right? Look, and even the people that don't develop AKI and run the marathon, they also get a big elevation in these biomarkers, just giving you a sense of how toxic that is for that. And then and then red are people that go for cabbage. And again, some people will go for bypass surgery, get AKI, and you can see what their biomarkers do compared to people that go bypass surgery and don't get AKI. All of those markers are much higher than that. The contrast-associated nephropathy looks like the safest thing you could possibly do to a kidney, right? And so what I'm trying to yell at you is that if we measure troponins, contrast wouldn't look toxic at all. When we did it, their troponins were negative if we had biomarkers. And then the other thing about these patients that go for arterial contrast, they are at higher risk for AKI. We know that. We know that there's a lot of AKI following caths. And so why are they getting AKI? If you are so smart, Joel, And you're saying that it's not contrast. Well, what is it? I want to propose a couple of things. So there's an interesting debate that raged in that cardiology, looking at radial access. So this is taking my hospital by storm. Almost everybody gets radial access here. But there was a time in the early aughts, mid-teens, when this was a raging debate in cardiology. And you can imagine how the debate went, that the older doctors were traditionally used a femoral approach, and the younger doctors like the radial approach. And the older doctors would say, well, you're cherry picking your patients. You are taking only the easiest patients to do this, and that's why your outcomes are better. And the younger doctors are like, no, we're not. Let's settle this with a randomized controlled trial. And this was the Matrix trial. They took patients with a strong indication for cardiac cath. They had STEMI. They randomized them to a femoral or radial approach. They had 4,000 in an arm. I'm so jealous of cardiology every time I see these studies. These are huge, massive, well-done trials. They're great, as much as that pains me to say. And their primary outcome was 1 year out, major adverse cardiac events, and there was no difference between the trial, but boy, they came close. Look at that p-value, 0.526, with an advantage towards radial outcomes being better than femoral. But the outcome of interest was net adverse events, and there was a significant advantage, p-value 0.0128, for better, lower risk with radial access. And this is why everybody's doing radial access, not because it's better, because it's as good, maybe a little bit better, and safer. That's why it's taken by storm. And among those net adverse events was contrast nephropathy. And we saw a nice about 10% reduction in contrast nephropathy with a radial approach. There was no difference in contrast volume. I'll show you that data in a moment. And if you read the conclusions of the study, they said, well, there's less bleeding, so there's less hypotension. That's why we had less AKI. This is a follow-up study that just drilled down into that AKI population. Red is femoral, blue is radial approach. Here you can see about a 13% reduction in contrast nephropathy with your traditional definition of contrast-associated nephropathy, but they do other definitions, and I love this greater than 3 times creatinine. This is a KDIGO AKI stage 3, and they had a 40% reduction in the AKI that I care about, the AKI that's severe. Boy, 40% reduction really is significant. And then looking at dialysis, this did not reach significance, but I think you would have a hard time convincing that it wasn't significant to the 8 additional patients that ended up on dialysis compared to with femoral versus radial approach. Like I said, the authors thought that this was a bleeding complication. I believe that that's not what's going on. I think this has to do with cholesterol emboli syndrome. So this is, if you remember, you got your aortic plaque, and we bring our cardiac cath here, and oops, we actually bump it as we go up the aorta towards the heart. We deroof that cholesterol plaque. We release these cholesterol crystals. They lodge themselves in the kidneys. These are the arteriole of the kidney. The cholesterol is dissolved out. We process the kidney biopsy, but we are left with these ghost clefts, which are classic for cholesterol emboli syndrome. They cause a lot of inflammation, and they cause what we usually consider pretty permanent damage to the kidney. This is a pretty devastating injury. This is, but I think when we look at cholesterol, and then they also, these crystals go elsewhere, and the classic story is they go to the feet, and you get these purple spots on the feet. This is from Images in Clinical Medicine from New England Journal of Medicine. And in prospective analysis following coronary angiography, we find cholesterol emboli in about 1 or 2% of cases, but in autopsy series of patients who died following aortic surgery or aortography, we find a much higher risk of this. And so I just think that we are probably missing a lot of subclinical cholesterol emboli syndrome. And some evidence of that comes from the TAVR data. So this is a TAVR study looking at risks of AKI following TAVR, and they looked at the cholesterol burden. They did this by CT scan, and they looked at the amount of cholesterol burden, and they measured it above and below the renal arteries. So presumably cholesterol burden below the renal arteries couldn't cause cholesterol emboli syndrome because it's going to flow downstream and affect the feet, but it's not going to affect the kidneys. But cholesterol in the aorta above the renal arteries would put you at risk for that. and that they looked at the risk ratio and the total atheroma above the renal arteries was the highest risk ratio for AKI following the TAVR. And so the idea here is that maybe the reason that a radial approach causes more AKI is because you have less likelihood to knock off a cholesterol emboli that's going to go to the kidneys. And then you start to think, well, if that's the cause of the AKI that we're measuring with a radial approach, maybe a lot of this AKI that we're seeing with cardiac cath has nothing to do with the contrast at all. It's the procedure itself that's problematic. One of the things that if you read this literature on cholesterol, of contrast-associated nephropathy, if they get AKI with following contrast exposure, they have this increased mortality. There's this high risk going forward. So if they develop contrast nephropathy, both 30-day and overall mortality is really bad. This looks like it's really toxic. And this is one of the arguments that makes you terrified of contrast-associated nephropathy is this mortality effect. I don't want to have a hazard ratio of 3.0 for something as important as mortality. But this is problematic data. So the implications of the study is you have a sick patient, the sick patient gets contrast, the contrast causes AKI, and the AKI causes death. But it could be that you have a sick patient, they get the sickness causes them to get the contrast, the sickness causes the AKI, and the sickness causes the death, and there's not this causality rate. And how do you differentiate that? One of the things that you could do is if you could find an intervention that reduced the AKI, if that reduced the risk of mortality subsequently, then you could say, well, the AKI caused the mortality. But if you reduce the AKI and the mortality remains the same, then there's not this causal sequence. This is the kind of the logical thing. So this is an article by Steve Coca, who's at Sinai in New York. He's a brilliant doctor. And he just said, well, let's just go through the literature and let's look for interventions that affect AKI. And he found there was indication, found interventions that reduced AKI by a 43%, bunch of studies, and they had no difference in mortality. And so that's interesting. But Steve, if you've ever met him, he's a pretty cynical guy. He said, well, actually, we can flip this around. Oh, I'm sorry, I don't have that slide. But the other thing that he did is he also said, well, there's also interventions that increase AKI. And that'll be just as useful for seeing if this sequence of events causes this. And it also did not affect this. So what ends up being is that it's not this sequence, it's the second one. And again, this study that Copa did was not just looking at contrast, it was looking at all kind of interventions, but it was just breaking that relationship, not necessarily for contrast, but for all different interventions, that a lot of the mortality we say associated with AKI is just associated and not due to the AKI. And so, kind of what we're seeing is we believe that a lot of the articles want you to believe that the contrast-associated AKI causes the mortality, and that age, CKD, and diabetes are all risk factors for contrast-associated AKI. But the problem with that theory is that age, CKD, and diabetes are also risk factors directly for the mortality itself. And so whether the contrast-associated AKI is important is questionable. And that maybe the contrast-associated AKI is indicative of this other age. And this is an example or a demonstration of what we call reverse causation, right? Is that when you see the wet sidewalk and it's raining, the wet sidewalk did not cause the rain, right? That seems trivial, but it can be difficult to determine when you're looking at this stuff. So we've seen a remarkable reduction in the dose of AKI that's been going on. It can be a remarkable reduction in the amount of contrast that we're giving. This is just talking with cardiologists, how much contrast did you use in the 90s compared to now? And we're just using a lot less of the contrast. And, you talk to them about the reasons. I already showed you the data, intravascular ultrasound. This has become standard of care. This is reducing contrast volume. We've moved from high osmolar to low and isoosmolar agents, which are almost certainly safer. Good data on that. When we do angiography, we have better scanners. They have biplane angiography. We get two views of the same vessel with the same dose of contrast, allows you to use less contrast. lower tube voltage CT scanners with software to denoise, just like your iPhone camera has gotten better since 2010, so have the CT scanners. We, we used to fill the entire ventricle with contrast to measure the ejection fraction. We don't do that anymore. Smaller catheters, so less damage to the blood vessels, all kinds of advances. Like cardiology has moved forward. This procedure has become safe. And so, what am I trying to talk about? Oh, this was looking at new technologies now allowing incredibly low contrast doses, nearly zero doses. So they're pushing the boundaries with new alternative technologies to allow very, very low contrast volumes. And I just want to look at, the contrast dose of 13 mLs is incredibly small. And we do EGFR, where we just estimate it from a serum creatinine, but in nephrology, we also talk about MGFRs, which are measured GFRs. And what do we use to measure the GFRs? We use a chemical called iothalamate, which is contrast. Like literally nephrologists are giving contrast to patients to measure their GFR. And we're like, don't worry about it. It's a very small volume. But that's kind of the same volume that we're starting to see in patients getting cardiac caths. And, I give this lecture and I hear people say, well, that's interesting, it's compelling, but I'd rather be safe than sorry. And I just want to bring you back to that initial study that I talked about at the very beginning, is that there's a consequence to safety. And this was Glenn Chertoff created this term renalism. And it's the underutilization of diagnostic and therapeutic interventions in patients with kidney disease out of concern that they are more likely to do harm in this patient group. And this is supposed to conjure images of sexism and racism and now renalism, is that we are treating these patients differently based on their disease. And in an attempt to be safe, to be helpful to these patients, we actually may be harming. And, if you just take a look at the scans performed with contrast, like as soon as there's a little H next to that serum creatinine, everybody stops doing this. And the use of contrast just falls off of a cliff. And this happens even in patients with good solid indications to get arterial contrast, people with coronary disease. And you can just see that patients with CKD are much less likely to receive PCI than patients without CKD. And then this is a study looking at invasive versus conservative care in patients with advanced kidney disease. And there was no difference whether you were aggressive or not aggressive, but it did give us some insight into this. So we had an invasive strategy where people were going to get contrast versus an optimal medical therapy where you were not going to get contrast. And does seem that the invasive strategy had a slightly increased initiation of dialysis compared to the non-optimal 36 versus 29. Not sure if it's significant, but there was a real significant stroke signal in the invasive strategy, which was not found in there. I think, a lot of this antiplatelet stuff that we're providing these patients may not be better. I talked about this study already. And then we talked about how rare this contrast-induced nephropathy is compared to AKI. And what happens is if you assume that all of your AKI is due to the contrast, it drops the curiosity. I don't know how many times I've seen a consult where a patient has acute kidney injury and they see that the patient got contrast and the fellow says, okay, I've already explained this. And they don't have any further curiosity. And oftentimes that disease is acute tubular necrosis, and we don't have any interventions for acute tubular necrosis. So there's probably no harm in that. But sometimes those patients may have acute GN and they need an intervention, or they have acute interstitial nephritis. And it's important that we don't have premature closure when we look at these patients. It can be a real concern. Results in anchoring bias and premature closure. And my suggestion to you is that we should think about contrast in kind of the same way we think about vancomycin, right? So yeah, does vancomycin typhotoxicity exist? Absolutely. Contrast nephropathy, if it does, it kind of exists below our limits of detection with kind of conventional statistics. With vancomycin nephrotoxicity, we have a lot of alternatives that we can give, right? Linezolid, ceftaroline, and daptomycin. Contrast nephropathy, not really good alternatives. how much do we worry about vancomycin? I mean, nobody worries about vancomycin. It's always give the vanco, and if they develop AKI, we'll call nephrology later, right? Which is not how we handle contrast, right? Contrast is like, wait a minute, better check a creatinine. Don't give it until it's absolutely clear. Get called nephrology, get the consult in advance. Like, it's just our concern about it is completely imbalanced. And does this result in delayed care? Again, vancomycin, we order it, we'll deal with this later. We don't even worry about dosing it. We give a flat dose to this. And for contrast nephropathy, we worry about it a tremendous amount. Again, this is not my this is my slide, but not my idea. This came from the Internet Book of Critical Care. I think an outstanding resource. And then these were just tweets that I said, just what's the attributable risk? What fraction of post-contrast AKI are due to the contrast itself, not hypotension, atheroemboli, other nephrotoxins, et cetera? Just looking at a vote, 787 votes. And then, and so again, most people think that, what is about 10% of post-contrast AKI, 1% were the big winners. And then the other question, what is the most likely to trigger a prolonged hospitalization by causing acute kidney injury? Vanco with therapeutic drug monitoring versus less than 200 mLs of iodinated contrast. I have a very enlightened group of followers. They understand what's going on. This is again the algorithm from the Internet Book of Critical Care, an algorithm for avoiding contrast nephropathy when CT scans. Start with the critically ill patient who needs a CT scan. Second, what is the glomerular filtration rate? Actually, forget it. I don't really care. Could IV contrast help the diagnostic imaging and provide better therapy? Yes, use it. No, don't use it. And I think this is the appropriate way to do it. Think about, why am I ordering the contrast? Do I need the contrast? Then order the contrast. We'll deal with the problems if it has a problem. How are we doing on time? I think am I done with here? The rest of this talk is just I can go into strategies about avoiding contrast nephropathy, which is, I think almost all the studies are flawed or negative. And I can go through it, but I don't think it's very helpful. Be happy to stop here and answer questions. Up to you how you want to handle going forward. What do you think? Questions? I love that.
I wanted to ask if you could do this talk about MR contrast gadolinium.
Yeah. So the gadolinium, there's a couple of issues there. So the one that is a traditional nephrology issue is the systemic sclerosis that we see after gadolinium contrast agents. And this was discovered in the early aughts, and our center, we identified 5 patients with this systemic sclerosis. It's a devastating disease. 4 of the patients died. 1 of them got a transplant and actually recovered nicely from that, but absolutely devastating. Clear association with early gadolinium agents, more developed, considered class 2 agents have been developed, and they have a much lower risk of this systemic sclerosis. In fact, there is a great meta-analysis that came out in Annals of Internal Medicine a few years ago, and they looked at, I think it was 5,000 administrations of these class 2 agents, and they had 0 cases of systemic sclerosis without that. There are some concerns about the data in the way they selected those patients, but I know that my hospital flipped over to the all class 2 agents after these initial reports, and we had 5 cases that we immediately identified as soon as this became well known, and we've had none that I've seen since then. I think that the situation has gone away with the adoption of class 2 agents. Happy to hear what your guys' experience has been here.
You know, it's terrifying, right?
It's yes, it's terrifying.
Sounds a lot like the contrast dye injury, which was a terrifying thing. You did everything to avoid it. You lowballed your diagnostic procedures because of your concern, but I've never actually seen it. And again, like you know, seeing different people saying that in the modern era, we're really not sure it's true. I'm wondering, in your experience in your institution, is there a cutoff you say, yeah, better not contrast?
So the way that I handle it is I am nervous about giving even the class 2 agents in dialysis. That's one of my concerns about this Annal study, is they did not differentiate between CKD and dialysis. I think the risk of systemic sclerosis is vanishingly low in patients with CKD not on dialysis. If you look at almost all the cases with the FDA, they're almost all on dialysis. The ones that they consider CKD, if you look at them, they're like, oh, they consider them CKD, but they actually at that time were on dialysis due to AKI. I'm like, I don't know, that sounds like a dialysis patient to me. And so, and then they grouped CKD and dialysis in this animal study, and there's not, and I might be misremembering, but I think I looked at this, there was not a specific examination of just the dialysis patients. So I worry that out of an abundance of caution, they included CKD patients, and that ended up making the data look better than it actually is. So for me, my imaginary line is dialysis patients, and I try to avoid gadolinium if they have dialysis. But if neurosurgery is saying that we really need the gadolinium, and oftentimes they do, and they have compelling indications, I give the gadolinium and dialyze them afterwards. That's what I do.
So you, because I've heard that it's too late. Once you've given it, it's too late. But if you dialyze like right after the MRI to dialysis, you think that's helpful?
That's what I do. I don't know if it's helpful. No, it's right. So the dialysis right afterwards is based on a pharmacokinetic study that said that if you dialyze them right afterwards for 3 days consecutively, you remove 95% of the gadolinium. And whether that actually reduces the risk has never been shown. And it's difficult to show now because this is something that we don't see. And I want to emphasize, we had 5 cases. I'm at a small hospital, a 400-bed hospital, and we had 5 cases of this supposedly rare disease. Like as soon as we knew to look for it, we saw it not everywhere, but in 5 patients. And that was 2004, 2005. We haven't seen it since. Like it really disappeared when we adopted these class 2 agents. I kind of think this is gone, and I'm still traumatized by the few patients I saw. I mean, honestly, it was horrible. These patients have this hard skin. It almost felt like wood. And I'd never seen this thing before. And I was like, this must be some kind of vascular problem. Let's get an MRA. I mean, I was doing the absolute worst thing for this patient. So, it's a bad memory. Yeah.
So for the IV contrast, like you showed the aluminium photo.
Yeah.
So it seems like all the data, all the studies coming out recently are proving against the existence of it, or it's not something detectable. Why did this become a thing that's talked about if like all these studies now are saying that we can't even measure it? How did it become part
So
of it?
I want to emphasize the current American College of Radiology and National Kidney Foundation guidelines are like, if their GFR is better than 30, you don't need to do prophylaxis. You don't need to worry about saline. You don't need to worry about bicarb, nothing. If their GFR is less than 30, maybe you need to be concerned about it, but not if they have heart failure. So GFR less than 30, but heart failure, again, no prophylaxis. So, and that's not the radical position. That's the American College of Radiology's position. That's the National Kidney Foundation position. That's standard of care now. Now, outside of that, the data gets thinner, right? Looking at people with just very low GFRs and existing AKI, I look at the data, I'm not impressed. And I do think it's going to be, and that to me, the important outcome that we should be looking for is dialysis. Let's look at how many of these patients after they get AKI actually need dialysis intervention. And that is really, really small. And that's why I get these consults to get, whether we should give contrast. And I'm like, you don't know who you're talking to, do you? Right? Because I'm writing my contrast as I'm walking up to there. I'm just saying, give the contrast, right? You feel it's indicated, go ahead and do it. I never say no. But why are people still studying this?
Concept that now in hindsight we've allowed to.
So it originally becomes the concept because if you're worried about an adverse event as a consequence of the disease, you're going to pick the most sensitive definition, not the most specific. You want to avoid any kind of complication. And that's what they chose. They settled on the most sensitive definition. And they're like, we actually, unlike the hepatorenal syndrome people where they're like, we want the most specific definition. We're going to do everything in our power to avoid contaminating this cohort with people with other causes of AKI. I think that's fine if you're trying to get a real pure definition. But if you're looking at a possible complication of this drug, or this therapy, you want to make sure, hey, we want to make sure we avoid any possible disease. And so we're going to get the most sensitive definition. And I think that sensitive definition has resulted in way too much alarm. And that's going to be that's a reasonable balance that you're going to get. You're like, you know, when you're sitting with a, you know, hypothetically just drawing this up without thinking about real world consequences, you're like, yeah, it makes sense to have the most sensitive. And what ended up happening is that the disease now, today, with today's agents and today's doses of contrast, is incredibly unlikely, right? And this highly sensitive definition results in us using it, way underusing the drug, possibly causing harm to these patients.
What do you think is the next contrast-induced nephropathy? What are we gonna be thinking about 10 years from now or 5 years from now? That was kind of similar.
Well, I think we were already there with metformin. I think our concern about metformin is way out of proportion to the risk. We assign so much of the risk to chronic kidney disease, right? We are always check the GFR, stop it when the GFR falls here. But when you see metformin-associated lactic acidosis, it's not because they kept the drug going on, they had progressive CKD, it's because they developed acute kidney injury, right? The risk is not CKD, the risk is AKI. And so that's one that way out of proportion. I don't feel too bad for it. I don't think metformin is the life-saving drug that it is made out to be. So I'm not, it doesn't kill me that we don't use metformin so much. But just last week, I had a patient who was on dapagliflozin, and they went for a bone marrow biopsy, and they were told to stop the dapa for 2 days before they got the bone marrow biopsy. What do they do? They're not intubated. I don't know why you have to stop dapa. How many meals do you miss for a bone marrow biopsy? And the patient wasn't even a diabetic. It was absurd, right? And this got written into some guideline that apparently SGLT2 inhibitors are so toxic that they need to be stopped 2 days before you do a bone marrow biopsy. And so I worry that when you tell patients that this is so toxic that you need to stop it before another therapy, you are teaching these patients that this drug is not life-saving, that this drug is dangerous. And that is concerning to me.
How does the thinking change when patients are in transplant kidney patients and that's working?
It doesn't change my opinion at all. Yeah, I mean, I still think the drug is toxic. Let me be careful with that. I am sure there are some cases of contrast nephropathy. And I think if you talk to nephrologists, they will tell you about the patient who, you know, was completely stable and they got contrast and they got severe AKI and they needed dialysis. And I think that happens, but I think it's on the order of, I gave a patient vancomycin and they had an anaphylactic reaction. Yeah, that sometimes happens, right? But that's not when we talk about contrast nephropathy. We're not talking about the 1 in a million anaphylaxis. We're talking about routine high risk development. And so, yeah, I think there's probably some toxicity here. I just think it's so rare that we just need to think of it as anaphylaxis. It's like, boy, that's the 1 in a million. It's unfortunate that happened to your patient. Let's manage them going forward now.
I think the key is, it's not really a question, but there's such a fear of litigation at the administrative level of every hospital that if we can show them that actually delaying care, we've all had those patients, had a bad outcome, that might move the needle, because now they just need any doctor to write a note clearing them for contrast. In the past, they would say, no, we need a nephrologist to write the note. We can't have any other doctor but a nephrologist. But if you go down a CT scan on the wall, because we don't even talk to radiologists anymore, the techs have a big list that says creatinine X, do not allow this test to happen.
All these different electrolyte findings on the basic metabolic panel, and then just kind of looking at that, the differential. And so let's remove BUN and creatinine because they're not electrolytes. We'll get rid of creatinine, chloride, because it's a mirror of sodium or a ghost of sodium. And you can just see that sodium stands alone. It is the most tightly controlled of all the electrolytes, with only a 7% spread between the upper and lower limits of normal. Remarkably tightly controlled. And in fact, regulating the salinity of our internal ocean is the original reason for homeostasis. Yet, among hospitalized patients, hyponatremia is weirdly common. And this is just a bunch of different trials that have looked at how frequent, not trials, but studies that looked at how frequent hyponatremia is. You can see the definition of hyponatremia varies and the rates of hyponatremia vary, but are crazy common. We see it all the time. We should be good at this, but we're not, right? The most looked up topic on UpToDate month after month is hyponatremia. There are only been a couple of months when that has not been true. One of them was when Ebola came to the United States a number of years ago. There was like one case of Ebola, and it was the most looked up topic on up to date that month. And of course, COVID in March of 2020 blew everything away. But outside of those unusual circumstances, hyponatremia is the most common looked up thing. This is a study out of Western Pennsylvania, seven hospitals, one of them academic, looking at patients with sodiums less than 120. They found 1,500 patients, and it's a simple question. How often are they fixing the sodium too fast? And definition of too fast here was going to be greater than 8 milliequivalents per liter in the first 24 hours. I think this is a pretty much an accepted definition of too quick, especially for chronic hyponatremia. We will represent that by the rabbit, slow correction by the turtle, and 41% of the time they were going too fast. That's not great. This is the nomogram. Looking at that, this is rates of correction in first 24 hours. And so there you can see red is bad, green is good, but actually not quite, because this stripe there in the first 24 hours, their sodium actually went down. You know, kind of safety tip, if the sodium's less than 120 in 24 hours, make sure it's not less than where you started. So it's just a narrow band in the middle. It's not great. This is the Macmillan data. I'm going to keep, so that previous data from Western Pennsylvania, I'm going to call that the George data. And this is from Canada, is going to be the Macmillan data. I may say they, it is a we. I am an author on this trial. It was the trial that radicalized me. We'll get to a little bit more of that later. But this is a large trial looking at 5 hospitals in Toronto, a decade worth of hyponatremia, everybody with sodiums less than 130, with just a few exceptions. It's 20,000 patients, largest hyponatremia trial ever. And here we found rapid correction in only 20%. So on first glance, it looks better than the George data. However, if you break it down by serum sodium, now remember, George data is everybody less than 120, and Macmillan is everybody less than 130. You can see greater than 120, we broke the speed limit only 13%. Less from 110 to 120, you get 46%, right on the button of what George found. And then in the patients that are the sickest, the ones that you're most concerned about, less than 110, 70% of patients were corrected too quickly. And last bit of data, this is the Kinoshita data. This is from 200 different ICUs across the United States, 1,000 patients, sodium's less than 120, again, rapid correction, 44%. So we're just seeing this 40% or roughly overcorrection or rapid correction over and over again. We should be good at this. We see it all the time. We are not good at this. And I think there's 2 reasons for this. One, there we go. One, diagnosis is hard, and the other one, the treatment is hard. And we're going to talk about both of those. We'll start with diagnosis. And so this is a pretty typical algorithmic approach to hyponatremia. This one's from the American Family Physician because it was easy to find on Google Images, but there's a million of these that you can use. They're all roughly the same. Some specifics may change from bit to bit, but what I want to tell you is that this algorithm, in the name of simplicity, lies to you. And I want to kind of expose the lies and kind of walk through that. I think this is a big problem with how this goes. So first off, I want to understand that we are talking about, we're really drilling down onto asymptomatic hyponatremia. If your patient is seizing, I don't want you to pull out the algorithm, right? Just give them the hypertonic saline. You need to address that first. So we are looking at asymptomatic hyponatremia, and the first stop is serum osmolality, right? And we're going to use that serum osmolality to determine whether they are isotonic hyponatremia, hypotonic hyponatremia, and hypertonic hyponatremia. And this is the first lie, right? Because we are not measuring the tonicity. In fact, you can't order a serum tonicity. You can do this in some specialized labs that use photography equipment to actually look at changes in red cell volume. But short of that, you cannot measure tonicity. And we measure osmolality as a proxy for that, but serum osmolality does not equal serum tonicity. And just as a reminder, I know you guys are all familiar with the difference, but I just want to, for the people watching at home that are not as clever as the people in this room, osmolality is all of the solutes in solution, whether they are osmotically active or not, whether they can move water or not. And tonicity is only a measure of the osmotically active solutes, the ones that are be impermeable to the membrane and draw water across that semi-permeable membrane. And because symptoms come from changes in tissue size, we are concerned with tonicity. This is the thing that we really want to measure. And that's why we categorize that hyponatremia based on its, hypotonicity, but we don't measure tonicity, we measure osmolality. And I wanted to show you an example of how this can bite you. So this is a real patient that I really saw, came in with a sodium of 123. Because everybody with hyponatremia gets put on normal saline at 100 cc's an hour in the ER, this happened, but this was an absolutely, I will say that this was an exceptional ER. They did draw additional blood and urine. And here's what we found. And I want to, looking at these labs, what is the first thing that sticks out to you? I'll give you the answer. It's the high osmolality. You're like, look at that. The sodium is 123. They should have a low osmolality. They actually have a high osmolality at 303. So we will go back to our handy dandy algorithm. We'll say they are asymptomatic. We check the osmolality. It is high. They have hypertonic hyponatremia. So they tell us to assess for, hyperglycemia, mannitol or sorbitol use, or recent administration of radiocontrast media. And so this patient has not gotten any radiocontrast media. They are not a recreational user of mannitol or sorbitol, right? It's just not an outpatient medication, right? They weren't doing, weren't smoking the mannitol. Glucose was 80. And so, I don't know, we're done, right? The algorithm has failed us completely, And so what the real answer is look for osmotically inactive particles in solution, BUN, ethanol, and toxic alcohols. So take a look, the urea is only 12. That's not very interesting. Oh, here we go. This patient has a very high alcohol level, okay? And so this patient's diagnosis actually is hyperosmolar hypotonic hyponatremia. And the important, now if they had, indications of hyperglycemia or mannitol or contrast, the hypertonicity causes the hyponatremia. So just making that diagnosis, getting to the diagnosis of hyperosmolar hypertonic hyponatremia, you're done. You have explained the abnormality. And in fact, you don't need to treat the hyponatremia. You just need to deal with the hyperglycemia or whatever is driving it. But in this case, the hyperosmolality does not explain the hyponatremia, and we need to go back and still work them up and just know that that elevated osmolality in this case was a distractor and didn't help you find the diagnosis. Okay, so what else is unusual on this lab? Anything else that you notice is unusual on this lab? How about the one that's circled? Yes, exactly correct. It is the urine osmolality that is low. Usually when you're making hypoosmolar urine, you're clearing a lot of free water, and that's going to correct your sodium. And so this one's a bit curious. And so on further discussion, this patient had been on a 2-week beer bender and hadn't been eating any solid food during that time, getting all their calories in liquid form. And this is a case of beer drinkers potomania. That's the diagnosis. And one of the things about beer drinkers potomania, it is exquisitely sensitive to normal saline. And sure enough, in 4 hours, the sodium goes from 123 to 130. Now, thank God this patient had a good neurologic outcome, because they absolutely exceeded the speed limit by a bit. And so this is a nice summary, a review in the American Journal of Kidney Disease, looking at beer drinkers potomania. And they reviewed 22 cases. They had 4 cases of osmotic demyelinating syndrome, the disaster that we never want to see. They had 4 deaths. Here are the sodiums in the cases of ODS and the cases of the 4 deaths. An important characteristic here is hypokalemia, which walks concurrently with beer drinkers potomania. I mean, alcoholics oftentimes have low potassium. There's no potassium in the beer, for one. It causes a renal leak, for 2. It causes hypomagnesemia, for 3. There's a lot of reasons why they get hypokalemia. But hypokalemia was very present in these cases, ranging from 1.3 to 5.1. Average Potassium in the patients that had osmotic demyelinating syndrome was 2.6. And you can see this also. This is the George data again. They ended up doing 300 patients got an MRI. They found 8 cases of ODS. And of those 8 cases, 5 of them were beer drinkers, potomania. So again, you see that concurrence, those things go together. And the Toronto data, 21,000 patients, only 12 cases of ODS. And the quote from the discussion session was a higher proportion of alcohol use history between 8 and 42% versus no ODS. And I will tell you, that this sentence wounded me when we were reviewing the manuscript. I hate descriptions of 8 to 42%. What do you mean 8 to 42%? Was it half or was it 10%? And what we ran into is when we were designing the study, first of all, we did not expect osmotic demyelinating syndrome to be 12 out of 20,000. Like that is a insanely infrequent. We expected a way higher rate. And one of the only risks in doing a retrospective review of rare diseases is possibly the potential to expose privacy. And so when we were negotiating with the IRB, the agreement we had is that anything that happened in less than 5 people, we will not be specific and just say less than 5 people. And we didn't think that would be a problem because we didn't expect we would have so few cases. And so all of a sudden, so what this means, 8 to 42% means less than 5 out of 12. So if it's 1 out of 12, it's 8%. And if it's 5 out of 12, it's 42%. And we can't specify more than that. So that's where that comes from. And, this is the thing about designing studies is you design them before you have the results. And so things that you concede to the IRB that you don't think will be an issue can come back to bite you. And this was an, let us just say the study was somewhat controversial. There was rather contentious back and forth with the reviewers and then with a number of letter writers after the study was published. And this is one of the areas that we got issues with. So I'm going to move off the osmolality and tonicity issue just in a summary. Hyperosmolar hypotonic hyponatremia. We see this with alcohols in the example that I gave you. The other case you will see this is on the nephrology floor. Oftentimes dialysis patients will have hyponatremia. They can't get rid of any water that they drink because they make no urine. So they tend to run with hyponatremia, but their osmolality tends to be high because of the high urea. So the alcohol is super high risk group. We talked about that for ODS, but uremia, it's weird. It's a kind of a lower risk for these neurologic things. And there's a question mark there because I don't think the data is super compelling, but it's certainly interesting. And when I give this lecture to my fellows, we do drive down and talk about why uremia seems to be protected, but I'm not going to talk about that with you guys. I'm going to move on further down the algorithm past our low osmolality. That's what we expect the osmolality to be. And the next step is to divide them into hypovolemic, euvolemic, and hypervolemic hyponatremia. And this is just like, as if you could just easily look at patients and immediately assess their volume status. This is a pure fiction. I love this trial. It's an older trial. It's 58 patients. They eliminated the easy ones, nobody with ascites, nobody with edema. They all had hyponatremia. And they brought in 2 professors and they gave them full access to the chart. They could look at the history and the weights, and the eyes and O's, and chest x-ray, and lab studies, orthostatics. And they just said, do you think this patient with hyponatremia will be saline responsive, presumably volume deficient, or not? Right? Super easy question. And the professor said, oh, there'll be 29 that are saline responsive and 29 that were saline unresponsive. And then they did the simplest study in the world. They gave everybody 2 liters of saline and they said, what happened to the sodium? And they found 15 patients were saline responsive and the professors were correct half the time. And they found 43% where they were unresponsive and the professors were right half the time. We have no idea what we're doing. We're terrible at this. And these guys, I mean, one of the professors was Robert Schreier, who is, if you had to make a Mount Rushmore of nephrology, he would be one of the faces. He's one of the greats in sodium and water, and he was terrible at this. So when we say, let's divide them up in euvolemic, hypovolemic, and hypervolemic, it's hard, and you're going to make lots of mistakes. And I think this is kind of walking, why is it so hard? So here's a typical history. Oh, you got a patient who's got a history of vomiting and they've got hyponatremia. And you're like, do you think this patient will be saline responsive? And the first thing you think is they're probably volume deficient, right? They've been vomiting a lot, so they're probably going to be saline responsive. And then you think, well, you know, vomiting, nausea is one of the most potent stimuli for the release of ADH and the cause of a lot of SIADH. So they probably will not be saline responsive. Or they're vomiting not because of not the vomiting is not the cause of the hyponatremia, but the hyponatremia has caused increased intracranial pressure and is now increasing causing the vomiting. And so like what seems like a simple history is a mess and really you can't get a causal relationship. And I think this is part of the reasons this is difficult. But you're smart and you're like, I'm not going to rely on my physical exam. I'm just going to take a look. Let's look at the urine sodium. There must be truth in the urine sodium. And no, that doesn't work either. So this is 3 studies that looked at urine sodium and they looked at whether these patients were saline responsive or not. And so the one all the way to the left, you can see looking at a urine sodium of 20, nothing there. You know, not good discriminatory. Urine sodiums below 20 seemed to eliminate saline non-responders, but above 20 had both responders and non-responders. But that doesn't hold off. The next study looked at urine sodium with SIDH versus hypovolemia. Everybody had elevated urine sodiums. And then the last one, again, almost everybody has a urine sodium over 20 and not a good discriminatory between the different diseases. You can read some of these algorithms will use 30 as a differentiator. Maybe that's a little bit better, but maybe not. I don't know if that really helps. I think this urine sodium is not nearly as good as we thought. Why is that? Maybe they have concurrent metabolic alkalosis, which can falsely elevate the urine sodium. Maybe they have significant chronic kidney disease that can elevate the urine sodium. Maybe they have a mixed picture. They have a little SIADH, they have a little volume deficiency. That makes it difficult. And a lot of these patients may have been on diuretics. It's just patients are complex. They don't act like the textbooks. The algorithm lies. This is just looking at uric acid, which I think a serum uric acid, I think is underutilized, at least among cases that I review of hyponatremia. Very few people are using this as a helpful discriminator. It tends to be very low in SIADH. If it's normal, it's not so helpful, but if it's low, it really locks in that diagnosis. And if it's high, it really rules that out. I'm a big fan of the serum uric acid. And this is a quote by Richard Stearns. And Richard Stearns is the editor of the Fluid and Electrolyte section of Up to Date. He is one of the great researchers on hyponatremia. I will be showing you data from Richard Stearns repeatedly throughout this lecture. And he had this to say about volume status. He says, although establishing volume status remains an important part of the traditional diagnostic approach to hyponatremia, when approaching a patient from the therapeutic standpoint, the clinician needs to be cognizant that establishing volume status accurately may not be possible. And I just think that's okay. Let's set that aside. It's just hard to do. Okay, it gets worse. Okay, so we have our categories here, and I just want to look at euvolemic hyponatremia. We classically want to rule out hypothyroidism as a cause of hyponatremia, and this data has come under assault also. So this is looking at the treatment of differentiated thyroid cancer, papillary and follicular. When we treat this, we start with a surgical thyroidectomy, and then you hold all thyroid medications for 3 to 6 weeks to make any kind of residual thyroid. Incredibly hungry for iodine because you're going to give them radioactive iodine and knock off the last bit of thyroid tissue. And so, and then after you give them the radioactive iodine, you lock them in a house without anybody else there. You tell them to drink tons of water to increase their water intake and clear out any of the iodine that they have. And then you got to take care of all their waste because it's all radioactive and toxic. But between a surgical thyroidectomy and then no treatment for their hypothyroidism for 3 to 6 weeks, you have created the world's greatest iatrogenic hypothyroidism. And so this is a retrospective review of 212 patients. Their free thyroxine at the beginning of their iodine treatment was 1.4, just 10% of normal, less than that, 5% of normal. TSH was 141. I've seen some TSHs over 100, but they are rare and usually get IV thyroxine. And they were off their thyroid medication for an average of 5 weeks. And at that point, they had 3 patients with hyponatremia, 1.4%, which is actually a little bit less than the ambulatory rate of hyponatremia. It looks like this was actually protective against hyponatremia compared to random ambulatory patients. Nobody had a sodium less than 130. Then they locked them in a room and told them to drink tons of water. And when they did that, now you saw some hyponatremia, but not that severe. They had 4 cases with sodiums less than 130. This is the graph. So the one you want to look at is going to be their sodium versus their TSH. Yeah. And so here there is no signal that the higher the TSH, the lower the sodium. In fact, just the opposite. The sodium seems to drift upward a little bit as the TSH gets to ridiculously high levels, like 500. And the R value is very, very tiny, and the P value is very, very high. There's no relationship here. Of course, you look at this one case, you're like, oh, look at that, hyponatremia and hypothyroidism with a sodium of 120. That was written up as a case report. Then textbooks say it has been reported, right? And now we're measuring a TSH in every single hyponatremia to the heat death of the universe, right? Like this is, it gets into the textbook somehow. Okay. We are now looking at, I believe we're looking at hypovolemic hyponatremia here, diuretics. So thiazide type diuretics are potent stimuli for hyponatremia. This is Netherlands, a study from the Netherlands, 13,000 patients, prescribed thiazides. 26% of them developed hyponatremia with a hazard ratio of 5. I mean, it's a potent stimuli for hyponatremia, and there seems to be a dose response. The lower the sodium, the higher the hazard ratio there. This is a treatment coming out of Great Britain, a study coming out of Great Britain. 3,000 patients were prescribed a thiazide. They had 32% of them had their electrolytes checked within 2 weeks, which is terrible, but and this one kind of surprised me. Hyponatremia was more common than hypokalemia. You think about how much we think about hypokalemia with thiazides, hyponatremia, a more common side effect of thiazides. And this slide right here comes right from my lecture that I give the second-year medical students when I teach them about salt and water. And I say, how does hyponatremia develop following volume depletion? And it doesn't matter what the source of the volume depletion, whether it's diuretics or diarrhea or vomiting. The important thing is that the volume depletion is sufficient to cause a release of ADH, not because of an increase in osmolality, but because of a decrease in perfusion, right? That hypovolemia stimulates the release of ADH, and then that ADH, in addition to causing vasospasm or vasoconstriction, also causes you to conserve water. That conserving water results in more water in than water out, and that causes the hyponatremia. And so this was accepted as a reasonable mechanism, but then somebody did some studies. This is Friedman's study. This came out of Israel in the 80s. They took 11 patients, had a history of thiazide-induced hyponatremia with sodiums down from 107 to 126, and then they gave them a single dose of 50 milligrams of hydrochlorothiazide. The only reason they also gave them 5 milligrams was amiloride, because that was the only form of thiazide that they had access to. So ignore the amiloride, though it is part of the protocol here. And the remarkable thing was how fast the sodium dropped. So the sodium started at an average of 138, and 6 hours later was down to 132. 6 hours after a single dose. Okay. And then this is what happens with the sodium. It drops like a stone in the first 6 hours, and then it kind of recovers slowly, and then way lower than the controls. And then remember, the argument that I was giving the medical students is that they got hypovolemic. The body weight in these patients in the first 6 hours actually goes up. It doesn't go down, right? And if you want to say, well, maybe they lose a lot of urine sodium, they're actually very similar, right in the middle between the two different control groups. Not a lot of urine sodium, not a lot of urine potassium. But the main thing that I want to focus on is that body weight. And the authors in the discussion suggested that there was a dipsogenic effect of the thiazides, that the thiazides made these patients thirsty. They didn't control how much water they drank. They drank a ton of water, and that caused the dilution of their sodium. But they didn't measure it, so it was just a theory. But this schema doesn't seem to be true. There doesn't seem to be any volume depletion. Their weights are going up. It just doesn't seem to work. This was a study, another study done more recently. This is 2015, similar study design, getting people with a history of thiazide-associated hyponatremia. And then they had a control group and they gave them a slug of thiazide, and you can see the sodiums drop very, very quickly. This is within 4 hours in this study. They also found the increase in body weight that we'd seen before, but in this study, they measured the ADH level, and their ADH level was actually a bit suppressed, like you would expect with a fall in sodium. And so this doesn't seem to correlate with what we would expect also. So again, we've shown that there's no volume depletion, but now there's not even a release of ADH causing here. So again, this kind of schema that we have where we think about how this is causing it, that seems to fall apart. We also know, this is from treating nephrogenic diabetes insipidus, that thiazides decrease urination. The traditional theory about here is that it causes volume depletion and you get reabsorption in the non-ADH dependent parts of the kidney. But there's some theory that it actually may result in increased non-ADH dependent fluid absorption in the medullary collecting duct. This is a phenotypic and pharmacologic evaluation of patients with thiazide-induced hyponatremia. And as part of this, and I just want to, this is kind of a little self-advertisement. I run an online journal club called NephJC, and we, as part of this journal club, we have nice summaries of articles. So we select good, important articles in nephrology. We do summaries of them. We provide visual abstracts for them. And so this is one of them that we covered. And here's your QR codes for both of these lectures. Both these, and then here's the visual abstract that we did for this one. And so there was a phenotypic analysis where we just said, well, what do these patients look like? Get some understanding there. And then they also did genotypic analysis, and they found some typical abnormalities. And I want to kind of describe what's going on. So normally, when you have ADH binds the V2 receptor, it causes pre-made aquaporin channels to get plugged into the medullary collecting duct, and that allows water to be reabsorbed. And this is what we see in the presence of ADH. Patients with the wild type prostaglandins transporter, this is everybody, prostaglandin that is found in the tubules gets brought into the medullary collecting duct tubules, binds this EP1, and it does what prostaglandins do. And if you study renal physiology, you find that whatever the kidney wants to do, the prostaglandins act as a brake. And so in this case, they prevent so much aquaporin being put into the medullary collecting duct, and so you just get less water reabsorption. So they modulate the response that's going on. This is just the normal response of prostaglandins. Patients with thiazide-associated hyponatremia, they have an abnormal prostaglandin transporter, this PGT that I have drawn here. This is the modified one. And so prostaglandin does not get transported to bind EP1 and ends up binding EP4. And that results in you don't get that modulation that you would expect from the prostaglandin. So this is the abnormality that was found in people with thiazide-associated hyponatremia. I want to point out in this entire explanation, I never showed a thiazide. The whole article goes through and doesn't explain what the thiazides do to cause this. I don't know. It's not covered here, but it is an interesting molecular abnormality that we found in these patients that are susceptible to this. And so I think the whole story has not been written, but this seems to be an important piece of the story. Big picture here is that this classic representation of thiazide-induced hyponatremia is an oversimplification. This may happen in some patients, but in the patients where we can find this to be reproducible, this is not what's going on. Our story that we tell ourselves about hyponatremia and thiazides, it's a fairy tale. It's just not what is actually happening. And I think this is, again, one of these oversimplifications. It fits into the schema, right? We told you these patients are hypovolemic, but when we actually look at these patients, their weight is going up. They're not hypovolemic at all. And so again, if you've ever used the algorithm to try to diagnose hyponatremia and thought that you were dumb because it wasn't working, no, you're not dumb. The algorithm's dumb. The algorithm makes shortcuts to make it make sense, but if it doesn't reflect reality, it's not helpful. It doesn't matter that it makes sense if it's not helpful. So that's diagnosis is hard. My modest proposal is we need to lose the algorithm and we need just to learn the physiology. And I don't think the physiology is that hard, but I think, yeah, I think, what happens is the algorithm is not reliable. Patients do not behave as the algorithm tells them they will. This makes providers feel incompetent and drives them into the arms of up to date. This is the algorithm failing and people getting frustrated. And, again, the physiology at a superficial level, we have hypotonic plasma that will suppress ADH release. With ADH off, you get a large amount of dilute urine, and that will correct the hypotonicity. The pathophysiology, couple things. One, the ADH remains on, right? So you want to shut it on, but it remains on. So you generate a small amount of concentrated urine that can be appropriate due to a decrease in effective arterial blood volume. This is cirrhosis, heart failure, hypovolemia, diuretics, maybe, and inappropriate ADH, CNS disease, pulmonary drugs, malignancy, all causes of SIADH also keep the ADH on. The other possibility is ADH actually gets turned off. However, the patient is still unable to make the large amount of dilute urine, either due to acute kidney injury, end-stage renal disease, or the low solute diet. And these are differentiable. You can determine whether the ADH is on or off by looking at urine osmolality. You can start to put together how to go down the diagnostic pathway if you kind of understand the flow. We're going to shift gears now. We're going to go away from diagnosis and go to treatment. And treatment in hyponatremia has kind of undergone a revolution in the last 5 or 6 years. First of all, of course, the snarky tweet. The most frustrating thing about treating hyponatremia is that the sodium wants to correct at one of two speeds, not at all or really fast. So what's new in the field is clinical trial data. This is the last 6 years, people are starting to actually walk away from the textbook, walk away from the chalkboard, and actually getting empiric data to see if this stuff works. And if you start reading these studies, you start to see some similarities. So one, they want to exclude people with fixing the hyponatremia is too easy, right? So patients that are volume depleted or patients with beer drinkers potomania, it's super easy. You give them a whiff of saline and their sodium fixes. It's just not useful to test those patients. Similarly, there's some patients where it doesn't matter what you do, you can't fix that sodium. The cirrhosis patients and the heart failure patients, right? Short of a liver and heart transplant, you really can't fix those patients. And so these two groups are removed from any of these studies on hyponatremia. And what that really means is if we're just left with syndrome of inappropriate antidiuresis or syndrome of inappropriate antidiuretic hormone, choose your acronym. They're really the same disease with two different names. SIAD is kind of the new hip name. It includes people with genetic resistance to or persistent secretion of ADH or a gain of function mutation. The ADH levels maybe low, but they have a gain of function mutation, giving them high antidiuresis. This represents about 44% of cases of hyponatremia. This is actually out of a Dublin Tertiary Hospital, looking at sodiums of 130, looking for etiologies. 44% SIAD. Here's the breakdown of the causes of their SIAD. It seems to ring true. I think medications are probably a little bit more common in my experience. And I don't see much adrenal insufficiency, though they found it in 4% of patients. And just in general, the key to treating hyponatremia is getting more urine out than water going in. You just get that right, and their sodium will get better. And the simplest way to get less water in is put them on a fluid restriction, right? Super easy stuff. We do this for all the time. How well does it work? So this was tested in a trial called the Effuse Fluid Trial. So in blue, we have the enrollment criteria. And if you look at that with eyes that look at a lot of hyponatremia, you say, oh, that looks like SIADH. Yeah, that's what they were trying to do. They were trying to find SIADH. This is how they found it, right? They had to have hyponatremia. They had to have a low osmolality, normal TSH, cortisol, no AKI, no diuretics, urine sodium greater than 30, urine osmolality greater than 100. So that's SIAD. And they had two different degrees of fluid restrictions based on something called the first ratio, where you take the urine sodium plus urine potassium and divide it by the serum sodium. If your first ratio is greater than 1, you have what we call dense SIADH, but a very difficult to treat SIADH, very, very severe SIADH. So they gave him a very strict fluid restriction if that was the case. The first ratio is one of the very few eponyms that was named after a fellow. He was a fellow at UPenn that came up with this ratio. He has since left nephrology and is working in private equity. So take that as you will. So relatively small study, 31 patients, and they looked at one of the outcomes was a sodium greater than 48. And in 4 days, they got about half their patients over a sodium of 130. I love this kind of endpoint of a sodium over 130 because I know at my institution, sodium's less than 130. They can't get procedures. They can't go to the OR. Just anesthesia says, no, we're not going to do those procedures. So I get a lot of consults where literally all they want is the sodium greater than 130. They need to get the bronchoscopy, they need to get the VATS done, and they need that sodium over 130. And that's my job. And honestly, if I said fluid restriction and in 4 days, you have a 50% chance that you'll be able to do the procedure, I'd be fired. Like nobody's interested in that solution, right? This is another fluid restriction trial. And largely found the same thing. They, fluid restriction helped their sodium somewhat. In 4 days, they got the sodium to go up 3 points. Just not dramatic. Next thing you may throw at patients is a salt tablet. And, you have a lot of experience correcting hypokalemia. And if you give patients with hypokalemia a potassium tablet, the potassium gets better and you feel like a hero. And honestly, if you like that feeling that when you give them potassium tablet, the next day the potassium is better, you really should consider a career in nephrology because all you get to do all day long is fix the numbers and it is incredibly satisfying. Sodium tablets do not work this way. So what we have here is this is just a concentration formula that's been solved for volume. And remember what we're trying to do is get the urine volume up so it's greater than the water intake. And one thing that we know is outside of kidney failure, solute in equals solute out. And normal solute intake is about 10 milliosmoles per kilogram in adults. And so we'll just since we know that all adults are precisely 70 kilograms, we'll plug in 700 milliosmoles as our daily solute load. And urine concentration in healthy kidneys goes from maximally dilute at 50 to maximally concentrated at 1200. And you can do the math and you can say, oh, look at the urine volume with the minimal ADH is 14 liters and urine volume with the maximal ADH is about 600 cc's. And that's kind of the range of urine volume in patients with normal kidney function and normal diet. And that 600 cc's is very similar to the definition of oliguria because that's where we come up with the definition of oliguria. If your urine volume is less than that 600, it is impossible for you not to be in kidney failure on a normal solute diet. And sodium tablets increase the urine output by increasing the numerator, increasing that solute load. And so here's what we have. We're assuming maximum ADH. So we have that urine volume at 580 cc's. We give them 1 gram of sodium chloride 3 times a day. 1 gram of sodium chloride is molecular weight is 58.4. That's going to be 17 millimoles, which will dissociate into a sodium and a chloride. That's 34 milliosmoles. So 1 gram TID increases the osmolar load by about 100 milliosmoles. And so instead of 800, from 700, you go to 800 and increases your urine volume from 580 to 670 or about 3 ounces. It's just not very effective. Okay. And in fact, what I didn't show you, I showed you this is the Effuse trial. This was actually the controlled group and the interventional group was fluid restriction plus furosemide plus salt tablets. When you did all 3 of them, that 48% goes up to 65%. It's better. It's just not great. Right. So the new darling in hyponatremia is urea. Are you guys using urea here to treat hyponatremia?
We don't have it on formulary.
Okay, well, you can get it at Amazon.
Yes.
Okay.
We haven't done that yet.
Right. So urea, urina with a clever little arrow going up, and urea aid these are urea packaged with sugar and flavoring, so it's somewhat tolerable. This alpha chemicals is urea that is marketed as a fertilizer for your plants, and it is much cheaper and available from Amazon and works the same way. I've never had the courage to give them that, but your mileage may vary. So it works exactly the same way, but the math works out differently because there's a lot more osmoles in a tablespoon of urea. So 15 grams of urea, which is the standard dose, it has a molecular weight of 60, and so that comes out to 60 or 250 millimoles. We typically prescribe one packet twice a day, so that's 500 milliosms a day. And all of a sudden, that person that was making 680 cc's now makes a liter of urine, and that really allows them to relax that fluid restriction or drink or get better sodium correction. And so here are 4 different therapies. Here's your conventional Western diet. They make 580 cc's on that with that maximum urine concentration. Put them on a gram TID that goes up to 670. I want to point out that just giving them potassium chloride, another way to increase their osmolar load, gets their urine volume up to 650, almost as good as a gram TID. Sodium and potassium are pretty much equivalent in this game. And then diet plus urea gets you up to 1,000. And then I did a second row here where oftentimes when I actually measure the urine osmolality and SIDH, it's not 1,200, it's only 600 because I don't know, they have chronic kidney disease and they don't get their urine concentration up that high, or their ADH level is not at maximum, it's sub-maximum. And here you can see these therapies they appear a lot more effective at these lower concentrations. This is a retrospective review of the experience at University of Pittsburgh using urea. They had 58 people, and in about 4.5 days, they got nice, solid improvement in sodium. They reported that no one corrected too fast and only one patient couldn't tolerate it. I will tell you that is not my experience. Most patients hate the stuff, and I get a lot of pushback from patients on drinking the urea. And then this was a retrospective systematic review and meta-analysis, 23 studies, none of them were randomized. 2 were prospective trials, 20 were retrospective, and my favorite is one of them, the trial design was unclear. I don't even know what that means, but it may have been an abstract, who knows? 8 were abstracts only, and 662 patients, mostly with SIADH, most of them treated with urea. Pretty good experience with them. Sodium goes up pretty nicely. But yeah, again, people hate the taste. And there's a couple of answers to that. So this was a trial that said, well, if the important ingredient is in urea is kind of the nitrogen in the urine, what about just using protein? So protein powder is 16% nitrogen. So you would get 4.8 grams of nitrogen per scoop. How much nitrogen is in urea? It is 47% nitrogen. So you can back calculate from that 4.8 grams of nitrogen makes roughly 10 grams of urea. And so urea, a typical daily dose is 15 grams twice a day or 3 scoops of protein powder. And this is something that I do. There's a lot of recipes for making protein powder digestible all over the internet. And so this is a way to help patients avoid the cost of urea aid, and maybe something you could even get in the hospital. And then this was a trial looking at 17 patients with SIADH, and they tried 90 grams of protein supplement daily. That's the 3 scoops. They did that for a week. They did a washout for 1 to 12 weeks, and then they repeated it with 30 grams of urea daily. And they had pretty much equivalent improvement in sodium with these 2 different strategies, kind of showing that these are equivalent. This is the TREASURE study. And then Roger Rodby, who is a treasure in nephrology, he's from Chicago. And of course, from Chicago, he's like, I've got the ultimate solution to hyponatremia. It is hot dog therapy. So here is his tweet with great pictures of hot dogs, emojis of hot dogs. But the idea here is that a hot dog has 10 grams of protein, and that will come out to, as we walk through the math, 57 milliosms of urea. But it also importantly has 500 milligrams of sodium in each hot dog. And so that's another 43 milliosms of sodium chloride. And so you add those together and you get 100 milliosms per hot dog. And so 2.5 hot dogs will equal 1 package of urea. My patients are big fans of hot dog therapy. And so maybe this is something you could do in your hospital. You're like, we don't have urea, but we do have hot dogs.
Right, they can take their own pee.
No, don't do that. Oh, come on. Nobody, You're not gonna be very popular.
Sorry, true.
This is when we talk about our fellows, we talk about strategies that are practice builders and practice killers. That's not a practice builder. Okay, I think the big hero here is tolvaptan. This is called the SALT trial. This was a trial looking at tolvaptan, the largest hyponatremia therapeutic trial, 243 patients randomized to tolvaptan versus placebo. In 4 days, they pumped sodium from 128 to 134. 42% of the patients got a sodium greater than 135. Do you guys have tolvaptan on
We
formulary
do,
here?
Even though we do not have urine.
No, I get it. And do you find tolvaptan to be effective?
Yes.
I find it to be highly effective. I agree. And in fact, the knock on hyponatremia is that it is too effective. And so here's a study that looked at 15 milligrams of tolvaptan, which is the standard starting dose. And in patients with a diagnosis of SIADH, they found a third of patients corrected too quickly, greater than 8. However, in heart failure, that was only 5%. And I think this is to me, this is super instructive, and it changes the way that I use the drug. I'm much more liberal with using tolvaptan in heart failure patients and much less concerned about overcorrection. But in SIADH, I'm very nervous about it because of this rapid correction. They gave you some data on the best predictor of rapid correction would be low BUN and low sodium. And then most of the same authors went back double dipped and said, well, what if we used a lower dose of tolvaptan? And so they cut the tolvaptan pill in half and used 7.5 milligrams versus 15 milligrams. They measured efficacy and its ability to bump the sodium by 3 points in 24 hours, and the efficacy was equivalent. And then they looked at overcorrection, way lower rate of overcorrection with half dose. The second author on this is J.C. Velez, who's a friend of mine. He said after this study came out, he started using a quarter pill of tolvaptan. And if anybody has ever seen tolvaptan, you must be really good at geometry to do that. It is a triangular pill that is kind of crumbly. Like, I think the pharmacist must hate him. I don't know how you get a quarter pill of tolvaptan without just getting tolvaptan dust. I don't know how he does it. Empagliflozin, of course, it does everything. Of course, it's going to be good for SIADH. This was a trial looking at this, randomized patients to placebo or tolvaptan, and this data does not look very impressive. The sodium seemed to be fine. Fluid restriction seemed pretty particularly good in this study. But if you look at the fraction of patients over sodium of 130, it was definitely better with empagliflozin. This was another study looking at empagliflozin. 4 weeks, 2-week washout, then placebo, or placebo, 2 weeks washout, then empagliflozin. Whenever you see this type of washout and flipping over, there's going to be some cognitive testing because you need to randomize what order you do these in so people don't get better. Sodium definitely got better with empagliflozin, but they did do cognitive testing, and cognitive testing also improved with empagliflozin. People are smarter with higher sodiums. Good to know. So treatment summary, fluid restriction has a small effect. Sodium tablets, small effect. When I say caution in heart failure and cirrhosis, just don't do that, right? In your heart failure patients, giving them sodium tablets will make them sicker. Obviously, we don't do that. We don't give patients sodium. And in cirrhosis, if you give them sodium tablets, it just goes into the ascites. It just makes that ascites worse. Don't do that. Keep those patients sodium restricted. Tolvaptan, reliably effective. Beware of overcorrection in SIDH. Of course, there's a black box warning about not using this in cirrhosis. I think this warning is way overblown. This risk of liver disease did not come from treating hyponatremia, but came from treating autosomal dominant polycystic kidney disease, where they were using the target dose in that study was 120 milligrams, and they were using this for months on end. And they still was a rare complication, but it was definitely a complication, but not from the tiny doses that we use for hyponatremia. Urea, reliably effective, tastes bad. Protein supplements, essentially as effective as urea, tastes better. SGLT2I, a small effect. And then I'm going to finish up with this study. A 6-year-old boy has a 1-week history of vomiting, diarrhea, and decreased appetite. Patient's alert with intermittent confusion, has dry mucous membranes and sunken eyes. Blood pressure is 99/68. Important to note that that is normal for a 6-year-old boy. That is not hypotensive. So hold your pressors. Height and weight are 50% for age. Patient is started on normal saline. They get initial labs, find the sodium is 96, and they change the sodium to 3% sodium chloride. Potassium is 5.8, sodium is 96, bicarb is 18. Diagnosis? Any thoughts? I hear the word adrenal insufficiency. Urine osmolality, or serum osmolality is 231. No metabolic. It looks like what? It looks like a combined respiratory and metabolic acidosis. No, let me say metabolic acidosis and respiratory alkalosis. Urine sodium is elevated, urine potassium is elevated, urine osmolality is elevated. Cortisol was reasonable at 10, but they then did a cosentropin stim test, and the cortisol 7.1. 30 minutes later, 7.1, 60 minutes later, 7.1. This is not an effective adrenal gland. Their ACTH level is crazy high, and their anti-adrenal antibodies are positive. Yes, this is adrenal insufficiency. Now, that 3% saline may be concerning. At 24 hours, the sodium was 96, a delta of 15, and at 48 hours, a delta of 14. So they definitely broke your speed limit for what you'd want to see in hyponatremia. And at hospital day 4, the kid that was acting normal now has slurred speech, ataxia, and clumsiness. Hospital day 5, they get an MRI, no evidence of myelinosis in the pontine region. However, there's diffuse basal ganglia signal increase on caudate and lentiform nuclei bilaterally. And this patient has osmotic demyelinating syndrome. What do you get? Now you got to talk to the parents. You think it's going to get worse, won't get better, or they'll have good recovery? Dad, you guys know. They discharged the patient on salt tablets, hydrocortisone, and fludrocortisone. Sodium remained stable. They weaned off salt tablets by 4 weeks. Repeat MRI at 5 months showed resolution of the swelling and hyperintensity of the corpus striatum. There were subtle, minimal volume loss of the putemmina bilaterally. Clinically, he is back to his normal self, progressing well at school with no obvious neurologic or developmental sequelae. This SING is the largest review of central and extrapontine myelinolysis, 541 cases starting in 1959 through 2013. Remember, imaging of the brain is like shockingly new, right? This is a diagnosis that we discovered in 1959, and we probably don't have good cross-sectional imaging into the late 80s and MRIs into the early 90s. Most of these diagnoses, or at least just under half of them, were necropsy, which does tend to bias you towards bad outcomes, right? These are all patients that are dead, and so it does make you think that these have bad outcomes. MRI or CT in 307 of them. Of the 307 that had non-death prior to diagnosis, you can see death is a shrinking fraction of the patients, right? Nearly half the patients in the 80s, only about 25% through 2011 through 2013. And recovery is also increased to right around half to over half, depending on which area you want to look at. But recovery is super important. Like, this is not something I was taught about osmotic demyelinating syndrome. I was pretty much taught, screw the brain up, it's kind of permanent. But disability is only found in about 25% of these patients. Possibly due to better ICU care, possibly better diagnostics. Here's the George data. Again, they found, I think, 8 patients with MRI evidence of ODS. That's right. And of those 8 cases, 5 recovered without neurologic deficits, even better than what you found in the SING data. And then here's the Macmillan data, 12 cases of ODS, 7 of them from patients with sodiums less than 7. So again, looking at the entire cohort, it was 0.05% of patients getting osmotic demyelinating syndrome. But among the patients with a sodium less than 110, it is almost 3%. super important to recognize that that low sodium itself is an important risk factor. I know we focus a lot on rate of correction, but rate of correction is the thing we focus on because it's the thing that we have some control on. We can't control how low the sodium is when they come in, but that's an important risk factor. And I think the other thing that keeps ringing in my mind is one of the most important risk factors for rapid correction of sodium is severe hyponatremia. So is the rapid correction of sodium the risk factor, or is it just a coincidental finding because it happens to be walk along with severe hyponatremia? And then the thing that really put us in the doghouse is we actually found more cases of ODS with slow correction than with fast correction. And so we wrote this sentence. We interpret these data to indicate that in most cases, rapid correction of serum sodium is not causally related to ODS. When we say most cases, that's 7 out of 12. That is more than half of the cases. And many people were upset by this sentence. In fact, in the Singh review, that's the largest review of this pontine and extra pontine myeloanalysis, 70%, 30% or 70 of the cases had a normal sodium. So again, this is not necessarily a disease of hyponatremia. And then this is the study from Sitapathy. It's 2 hospitals in Boston. That's code for Harvard. 3,200 patients with sodiums less than 120. Average sodium was 116. They found 7 cases of ODS. Again, a much higher rate of ODS among patients with sodiums less than 110. And then they looked at speed of correction, and then you can see the distribution of their 7 cases, with most of them being in that medium range of change delta sodium of 6 to 10. But and then they good recovery rate, 5 full neurologic recovery, 1 with gait imbalance, 1 was lost to follow-up. But what they did that nobody else had done before was they said, we've been so focused on osmotic demyelination syndrome and neurologic outcomes. Let's take a look at mortality. And the reference group was this middle group. And what they found was that the overall mortality was way worse with slow correction of sodium than with fast correction of sodium. And this is pretty upsetting because the deal that we were taught was that the only risk in the treatment of hyponatremia was this neurologic outcome. And Sitapathy says, well, I don't know about that because the people that you corrected very slowly had way higher mortality than people that were corrected quickly. Okay, now, and then they broke it down and divided it by different etiologies. Now, the common criticism of this study is that it's not the hyponatremia that causes the increased mortality, that it's the diagnosis, right? The reason that people correct slow is not because your nephrologist was carefully measuring every drop of hypertonic saline that was going into the patient and carefully controlling it, is that the patient had cirrhosis, or they had dense SIADH from their lung cancer, and their cirrhosis killed them, and their lung cancer killed them, and the slow correction was because they happened to have a disease that you couldn't fix. And, maybe, but again, they did separate out the cirrhosis and still found the signal there. They did separate out the cancer. They did find the signal there. Same thing with heart failure, but they didn't drill down and say, well, what was the EF in these 2 different cohorts? Was the heart failure much more severe in the slow correction than the fast correction? This is an excellent criticism of the study, but my feeling is when you have, look at the number of patients with slow correction, 1,200. They had one case of ODS there. And they had really high mortality, very high. And so maybe what I just described accounts for a lot of this effect, but I don't know if it is completely accounts for this difference in mortality. And if there's even some residual effect of this slow correction. And to me, it seems unlikely that the body invests so much of the mechanics of the brain hormones and kidneys are about regulating serum sodium. It seems weird that that would be irrelevant to survival, that all that stuff that the brain does, no, it doesn't matter, which is kind of the argument on the side of slow correction. This is Kinoshita. I showed you this data earlier. This is 200 ICUs in the United States. Found exactly what Sithapathy did, looking at rates of mortality being significantly worse with slow correction, better mortality data with rapid correction, no difference with neurologic outcomes. So this is my concluding slide. I think I'm fine. Contemporary data shows that ODS is very rare. Higher rates are seen with the most severe hyponatremia. Hypokalemia and alcohol use disorder are consistent risk factors for this outcome. Relationship of ODS to speed of correction, let's just leave it with inconsistent. Diagnosis is hard, treatment is difficult. Some of the assumptions around the goals of therapy are failing in the face of modern data. Thank you. I'm happy to answer any questions. What do you got?
Do you recommend any rate of correction based on the sodium value then?
Yeah, I am the most Catholic of Catholic. My fellows hate me. I am incredibly fastidious and go for less than 8 per 24 hours.
For any value of sodium?
Oh, no. I don't much care if it's above 122. And really don't get too excited about it unless you're below 118 or so. What do you do?
4 to 6, 6 to 8.
Now, tell me about the 4 to 6. Because that's really, I'm just saying that's really slow. But so tell me more about that.
Initially consult with trainer, but like we used to go 4 to 6, and then if it is more higher, then I think 6 to 8.
Yeah, so the guidelines say that 4 to 6 should be used in patients with high risk of ODS. So you're going to be looking for patients that have concurrent hypokalemia, severe hyponatremia less than 105, seizures, cancer, thiazide use. So they're supposed to assess their risk, individualize it, and reserve that very slow rate for patients with the most severe hyponatremia, the highest risk of ODS.
Quarter to a third of our patients have alcohol. So I'm wondering for our patient population.
Everybody should be considered super high risk. Yeah.
And I would say like, actually probably about 75% of our patients with hyponatremia have some kind of alcohol risk. So I would say that most of our patients, I would consider higher risk.
Mhm.
Well, just from that perspective.
You should push for tolvaptan. No, not tolvaptan. I mean urea, because it's really the safest method that we've seen for slow correction of hyponatremia. You just, especially, yeah.
It's true. Yeah, we really need to work on
And
it.
stuff's not, and the stuff's not, and the point is, it's not expensive.
Yeah.
Stuff is, cheap.
Way cheaper than tolvaptan.
There's nothing more expensive than that's not true. There are lots of drugs more expensive than tolvaptan. Tolvaptan is a couple $100 per pill. I'm sorry, what was that? So I just tell patients to go get whey protein supplements on Amazon. They have a big bucket, like a weight builder, a weight lifter. What do they call them? Bodybuilders is what they call them.
Yeah.
That's what they call that.
I look at me looks at me.
I don't know. You look like an athlete. That's why you look like an athlete. Yeah. Okay.
Patients that are like high risk for ODS, very low sodium, alcohol use disorder, elderly, that sort of thing. Where does like DDAVP climb? In your opinion?
DDAVP clamp.
DDAVP.
Right. So, yeah, that's why this is one of the things that I do to allow slow correction of hyponatremia. And the idea of the problem with hyponatremia is, especially if they have volume deficiency as the etiology. And as soon as you correct the volume deficiency, then they have this massive water diuresis and the sodium skyrockets. And so probably the best strategy to avoid that is you start them on DDAVP, which is essentially pharmaceutical ADH, at the outset of treatment. Before you do anything, give them in addition to the volume deficiency or their alcohol, their Bierdecker's potamania, they now also have iatrogenic SIADH, and they will not have that water diuresis when you correct their volume deficiency. It does, because they now have SIADH, and you know that giving saline to SIADH causes the sodium to fall down, you're forced into now giving them 3%. So I will then ask you, how difficult is it to run 3% at your hospital? It is nearly impossible for me to get 3% to my patients. The hospital makes it very, very difficult. They have to be in the ICU. They have to have a central line. Okay, well, I can do that, but it makes it just a big lift for me. What about for you guys?
The vertical lines and the.
For anybody, it's cowboy heaven here.
Like our rules from pharmacy are like maximum 30 cc's an hour through a peripheral, so you can even get away with like up to 60 cc's if you do it through two peripherals. which
Oh,
is
you guys are in heaven. Okay, so you guys are good. Okay, so you don't have any. Okay, yeah, so, okay, so yeah, so for you guys, that DDAV clamp's not gonna be much of a barrier, and that would be the way to handle that. Yeah, running 3% without a clamp is a little too cowboy for me.
And the.
You spending so much time telling us why we should not algorithmically approach hyponatremia. What's your algorithmic approach to hyponatremia?
I don't,
I'm partially getting you, like, what are the lab values that you base your judgment on? And I mean, don't go for like the dry as a bone versus the legs like this size patient, but rather the patient where you're kind of lost in the middle, like I don't know what volume status is. You get the urine studies, I assume, you get serum uric acid, sounded like you like that. What are the?
here, what ends up happening is, in the patients that are ambiguous, right? You get the patient, there's patients that are clearly one way or the other. You got the patient that's clearly heart failure, clearly cirrhosis, those are not difficult. And you get the patients that are, clearly volume depleted, that, they're dry as a bone. Those are, but the ones in the middle, I embrace the ambiguity and say, not really sure what's causing this. What we're going to do is we're going to start with the saline infusion, and we're going to see if this patient's saline responsive. And if they're not, and what's the worst thing that can happen? Their sodium goes down. So I'm a big fan of the therapeutic trial. Give them some saline, see what happens. And that will, then the patient will declare himself, right? If the sodium goes down after you give them saline, you got your diagnosis of SIADH. It's the only thing that'll do that. If the sodium goes up after you give them saline, be careful, because there's oftentimes a mixed picture. I see a lot of patients that get better for the first 24 hours of saline and then get worse after that. I think that they had a mixed picture, two different diagnoses. Again, not part of the algorithm, part of reality. And then so early on, volume depletion followed by SIADH. And so I just embrace the ambiguity, document it in my note, and go forward with that. And don't feel the need to make a specific diagnosis at the outset of treatment, because the treatment's going to be the same. Still looking for the same target sodium correction, and going with the saline usually doesn't get you into trouble. If you think that the patient is going to rapidly correct at the patient, then go with a clamp, and they have severe hyponatremia with risk of ODS.
So when teaching medical students, I think we're teaching them the algorithmic approach. Basically, it's just so that they can understand like why in this group should be this and this group. And
Yeah.
normal patients will often have, several things going on at the same time. I mean, sort of, I think of it kind of similarly to, we teach about anemia in MCD groups, even though normal patients have nothing, like their anemia has nothing to do with what MCD they actually have, right?
I would, what I'm saying is I don't, and I think that you don't have to do it. Like, even when you do anemia, it's not so much an algorithm, right? I think categorizing is different than do this, and then if this, do this, which is what happens with hyponatremia. And I think that is we are responding to people complaining that it's complex by giving them a tool that doesn't solve the problem and makes them more dependent on the tool. It just, it doesn't.
Teach the groups, you just don't use it as a tool.
I don't, yeah. The concepts are important, right? The concepts of what, measuring the osmolality and knowing how to respond to that osmolality. Like, I think it's important to know sometimes the sodium can have a high osmolality. What do you think about with that? But don't fall into, if the osmolality is high, they have hypertonic. No, they don't. You didn't measure the tonicity, you measured the osmolality. So what are the possibilities there? Some of them are hypertonic and some of them are just hyperosmotic. and walk through that. Right, yeah.
For the fireside, you use treatment. So like, it looks like SIDH, smells like SIDH, but it really isn't. Is there like, differentiating factors, like, would the uric acid be elevated, so decrease, like, the thiazides usually due to hyperuricemia, or?
Yeah, so that still result in hyperuricemia, though their fractional excretion of uric acid is elevated like you see in SIADH.
Any other differentiating factor, like, apart from obviously, the patient takes a diethylamine. That'll do it.
No,
Do it.
because they respond to saline beautifully,
Right.
and thiazide and SIDH don't.
And is that just for thiazide diuretics or also for thiazide like?
It's for thiazide-like also.
In what sodium value will you study evaluation for hyponatremia? Any value below like 135, or you go down and wait until it will go like? below
So we
150?
see adverse, from an epidemiologic standpoint, we see adverse effects from hyponatremia starting at less than 135. So increased risks of falls, decreased bone mineral density, decreased cognitive ability starts at sodium at 134. But it's subtle, and it'll be difficult. It's something that you can pick up epidemiologically and probably not in individuals. And those sodiums are incredibly frustrating to treat, right? Like, it's hard to put somebody on a fluid restriction. People just don't abide by it or don't abide by it enough. And so I usually waive them. I'll avoid a thiazide in those patients, right? I think you're doing your patient a disservice, even if they only have subtle hyponatremia, thiazide. And I think you got to weigh, like, is that really the only way you can get their blood pressure under control? Have you tried a loop diuretic, right? So, but I think the evidence shows that the even very modest hyponatremia results in adverse outcomes for patients.
For the two professors who are trying to decide the volume, status, they weren't at the bedside, right? They only had access to the charts.
That is correct. We all set here?
One last question.
Yeah.
Have you ever heard of do you ever do the, just a little bit of saline with the Lasix? So that's what we do. So there's someone here who's like a huge proponent of it, performance hypertonic. I've gotten a lot of, no matter what kind of hyponatremia it is, I feel like I do see some response to saline combined with a little bit of Lasix.
So they used to call it the Schreier method. This is what Schreier advised doing. He used 3% and furosemide. It's not how I approach things. So I've, furosemide and salt tablets I've done. So I don't have a lot of experience with it. You think does it work?
It does, but.
Great. I mean, here's the deal. Loop diuretics are good for hyponatremia. It's a good strategy, but you don't want to induce volume deficiency. So you're correct. You're preventing the volume deficiency, and saline should work great for that. Yeah, it is a system that should work on paper and looks like it works empirically. Yeah,
I think it works, but I was just curious.
you should do a case. No, honestly, that's something you could do. That's a great fellow project, because you probably have a bunch of patients and you can retrospectively do that. And if you're being done by a nephrologist, you probably have a bunch of urine studies. You can put that together, case series, and that would be a cool little study. Give it a cool name. Yes, ChatGPT. That's right. Okay. Thanks.